Good morning, everyone. I'm Dr. Qureshi, and I hope you guys can all hear and see us. We have a good, exciting meeting today. Dr. Rahman Sheikh is going to be talking about anal fissures and pruritus first. So we twisted this around so that I can just speak through for an hour about the anorectal exam and uh, and office management of hemorrhoids. So Rahman Sheikh is assistant professor of medicine and at Baylor College of Medicine. He's a colleague of mine and was is very active in the anorectal disease clinic. That will be followed by myself talking about examination, DRE, anoscopy, and I have some exciting videos, or at least they're exciting to me, maybe not anyone else. Then we have our colorectal surgeon, who is Yasinia Rojas Khalil. She is associate professor at the colorectal department here at Baylor College of Medicine. And she will be followed by Jessica Bernica, who is assistant professor of medicine here at Baylor College of Medicine, and also one of my ex-fellows and has now taken over hemorrhoid management from me, it seems. And followed by that, we're delighted to have physical therapists for pelvic floor training and biofeedback training who will tell us how they do their um, pelvic floor training. She's from the Methodist Hospital. It's Catherine Osterhaus, and she will be telling us who qualifies for their treatment, how they make the diagnosis and treat us, and then treat the patients. And following that, I'll talk about how you can start your own anorectal clinic and what you need to look out for and what you need to do to safeguard from a medical legal aspect. We have question and answers after each session, and please feel free to ask questions and we'll address them as we can. So we will start with Dr. Rahman. Could you take it away then with your anal fissures and pruritus talk?
Of course, of course. Thank you, Q. It's always good to have you behind me.
I do the
Thank you. Well, I'm starting this off, so I had to kind of step up my joke game. So thank you all for joining. Thanks for as always putting this together, Q. When I was a fellow, I feel I was very uncomfortable with anorectal disorders until I kind of worked with Q, and I think having him as our faculty has been really tremendous for us and the fellows. But I also realized that I think many providers and patients, one, don't know that we can manage them and that we should be managing them, and we can provide a lot of really valuable care to patients, because sometimes the most thankful patient is the one whose fissure or hemorrhoid you treat, because they can sit comfortably and they can poop properly. And so this is a very valuable session. So I'll be talking about anal fissures and pruritus. So the goals are going to be to recognize anal fissure, explore a therapeutic algorithm for managing fissures, develop an approach to evaluating pruritus ani, and review management strategies. So an anal fissure usually, and I know Q goes into this in great detail, and usually when someone has perianal pain, unless it's a thrombosed hemorrhoid or a grade 4 hemorrhoid, usually hemorrhoids are not painful. So if they're telling you it's pain, it's most likely a fissure or something more nefarious. So, a fissure is just what it sounds like. It's a tear in the anal canal. It can be quite painful. It typically results from the passage of something very difficult, something very hard, often with straining repeatedly over and over, or anal manipulation, anal receptive intercourse, recurrent enemas, things of that nature. But those are usually the cause of anal fissure. If it's an acute fissure, you may simply have a tear on the exam. If it's a chronic fissure or a healed fissure, you may simply see a sentinel skin tag on the outside. And then if you look on the inside with a flexor colonoscopy or even anoscopy, you'll see hypertrophy anal papilla. So the vast majority are posterior midline due to a decreased blood supply and the highest pressure with defecation. It's usually the two reasons why most of the ones you'll see are posterior midline. A small portion are going to be anterior midline. Anything outside of the midline, anterior, posterior, think about other etiologies. That's when we start thinking about IBD, HIV related, whether it's malignancy or whether it's atypical infections or STIs. Sorry, everybody, I just need to clear my throat. So here are two examples. So the example up in the top left is an acute fissure. You can see a tear at the 6 o'clock location. And then the next picture you see, actually, you can see a prolapse hemorrhoid, but you can see a skin tag here. And then internally, you see some hypertrophy anal papilla in the setting of hemorrhoids as well. Here is an atypical. These, as you can see, there's not posterior midline. You have one on this side. This is more like a 4 o'clock. You have one at 3 o'clock. This is HIV related. So the diet, the goal, there's just like most of the things we do in GI, there's lifestyle interventions in terms of symptom management. There's dietary and lifestyle changes, and there's medications, and there's procedures. So dietary and lifestyle interventions include fiber supplementation. The goal is around 30 grams of dietary fiber or adequate fluid, along with adequate fluid, so you have soft bowel movements, regular bowel movements. Sitz baths helps with healing. It also helps relax the sphincter, so you may have better healing with it, but it provides symptomatic relief. And then limiting time on the toilet. The longer you sit, the more the blood pools, the more there's pressure as you try to evacuate your stool, the more likely you are to have some kind of a tear. So this is probably one of the most important slides in this entire like 30-minute session. So topical therapies. This is really his first line. If someone's coming to clinic, I always tell them to take adequate fiber. I go over lifestyle changes, but we always do a topical therapy. So there's about 4 or 5 options. We'll start from lidocaine, we'll move on up, we'll go over the literature, and that way it can help guide you with the decision you make as to what you want to prescribe. Lidocaine essentially is just going to numb the area. It may provide relief. It may not. The chances of this being the sole driver of healing is less likely. Nifedipine is something that we prescribe often. In a head-to-head study looking at lidocaine plus stool softener, which was the control, versus 0.5% nifedipine ointment twice a day for 4 weeks. The nifedipine arm had healing in about 70% of the patients. Only 12% healed in lidocaine arm. So just doing lidocaine alone is probably insufficient. You need to have something that will relax the internal anal sphincter, which will prevent spasm and also promote blood flow to the area. In the nifedipine arm, about 6% of patients had headache, so it is something to caution patients about, although in subsequent studies, that number is a lot less. My son just walked in. Diltiazem is another calcium channel blocker. In a prospective review, patients given 2% diltiazem within 2 to 3 months, 3/4 of the patients had a response, had a healing of their fissure, and headache was only seen in 2% or less. So you're asking, well, what about oral diltiazem? I have patients already on it. Is that sufficient? Well, in a study looking at oral diltiazem versus topical diltiazem, only 38% had healing at 8 weeks versus 65% in the topical diltiazem arm. So nitroglycerin is a common ointment that is prescribed for this reason. Comparing diltiazem versus topical nitroglycerin, a substantial number had healing with topical diltiazem at 12 weeks. Almost 90% on the topical diltiazem, and topical nitro had about 70% healing. That being said, systematic review shows very little difference between the two, and nitroglycerin has a higher rate of headaches. So now we're like, okay, well, calcium channel blockers are clearly in the clinical studies better. Which one should I do? And the nitro versus diltiazem arm, diltiazem at 12 weeks had really high rates of healing. Well, in a head-to-head comparing 0.3% nifedipine, which is lower concentration, versus 2% diltiazem, 77% versus 54% favoring nifedipine had healing at 8 weeks. So our go-to is lidocaine 5% plus a nifedipine 0.5% compounded ointment BID. Usually we put in the instructions is we put a pea-sized amount on either an applicator or the fingertip, and you want to place it just about within a centimeter into the anal canal. You really want to get over the fissure, and you want it to get to the underlying intraanal sphincter. Now it has to be compounded. Depending on what part of the city and state and country you are, it may not be as easy. A few years back, one of our MAs discovered that HEB would allow you to fax to central HEB compounding, and they would send it to your local pharmacy. I have not had as much luck with that more recently, but there are numerous compounding pharmacies. And so some either will reimburse, the insurance will reimburse after processing, they require you to get in network. So this is one of the few barriers is finding a compounding pharmacy, but it does need to be compounded. So Botox and surgical sphincterotomy. So if the patients do not respond to topical therapy and lifestyle changes, then you have to think about alternative procedural options. So Botox injection or botulinum toxin was previously, prior to studies looking at all these different non-invasive therapies, was one of the preferred options, and it was thought to be a chemical sphincterotomy. So in a study looking at Botox versus placebo, about 3/4 of patients had success with Botox versus placebo alone. Now, if you combine nifedipine plus Botox versus nitroglycerin, you get almost every patient has healing of their fissure. So the goal is to inject about 25 units posterior, lateral to the posterior midline on both sides into the internal anal sphincter. Now, I've done this. The challenge is storing Botox. And so if you have a safe method to store it, you can do it in the clinic. I know the colorectal surgeons may have it in the clinic. We have it in our endoscopy lab, so we tend to do it with the sigmoidoscopy for that reason. But you don't necessarily need to. It can be done in the clinic. It's effective until innervation reoccurs, which can take months. So, despite doing all that, your patient may have persistent fissure. I have a few, in the last 6 years, it's not super common that I've sent to the surgeons. Usually, our management is sufficient. I really only had sent 1 or 2 patients. I think Q and Dr. Bernica can give their experience, but I haven't had many because most time non-surgical options are sufficient. In a large cohort of patients, nearly 500 patients, virtually all patients had healing of a chronic fissure with a tailored lateral sphincterotomy. The question is, well, you're worried about, is there incontinence? Well, 5 years after surgery, only 1% had incontinence to solid stool, 8% had minor incontinence. So that is a risk we have to tell patients about. That being said, having that severe pain for many, many months, sometimes people are willing, they may just be willing to deal with it and deal with that small risk. So the majority of anal fissures occur in the posterior midline with a small percent in the anterior midline. If there is any other location, please think about alternative possibilities. I'm just went through this right now. I had a patient referred for a fissure, and then I sent to, I had a colonoscopy some years back. Did not want me to examine for personal reasons, so I had the colorectal surgeon see her, and they were like, you know what, I think we should rule out IBD. So we just went through that. It was negative, but obviously if a fissure is lasting a long time, it's non-healing, atypical, think about alternative etiologies besides just a bland fissure. Obviously, for all patients, there should be fiber supplementation, sitz baths, and limiting twirling time. Medical therapy options, we strongly recommend lidocaine 5% and nifedipine 0.5% BID, and train for a minimum of 4 weeks, but up to 12 weeks. Now, while you're going through this, you will also need to address their constipation. So some people have already done the fiber and Miralax. Think about pharmacologic therapy for constipation, and also think about outlet dysfunction or pelvic dyssynergia. If there's a non-healing fissure, despite medical management, consider Botox to the internal anal sphincter, and if it continues to persist, then a tailored lateral sphincterotomy. Again, we at Baylor can offer Botox. It's usually done with a sigmoidoscopy because of how we store our Botox. But if you do get to that point, you consider developing a relationship with a colorectal surgeon so they can help with the Botox or the sphincterotomy. So that concludes the anal fissure portion. I do want to talk about a challenging subject for many patients, which is pruritus. This is I always like to talk about this patient because this is probably one of my most challenging non-IBS patients so far. Was a patient with MS who came to me with pruritus, and this was like a 2+ year ordeal for him. So I was obviously not sure that I would be able to fix it if it's been going on for that long. But we went down this route. He first saw his PCP, who recommended conservative therapies. Yeah, so someone had mentioned 20. What literature that I read is about 25 units total. Um, so symptoms had persisted despite loose-fitting clothing, doing conservative management. This I wouldn't recommend, but they did an anal swab, and of course it has all the enteric flora. They got prednisone and loroquine, mild relief. They did a swab for viral and fungal, and was negative, but they still did topical and nystatin, didn't get better. So that's when he established with me. I thought, well, we've tried numerous things. I don't see anything perianal, maybe a skin tag. We did a colonoscopy. The only thing we really found was some large hypertrophy in the papillae and hemorrhoids, as you can see. So referred for colorectal for the skin tag excision, and he had a surgical hemorrhoidectomy as well. Again, pruritus continued. I gave a low potent topical steroid, which provided mild relief, but symptoms still persisted. For a berry cream, symptoms still persisted. We tried capsaicin cream, and he sent me a long, scathing MyChart message saying, "My hands are burning. My hands are burning. This is horrible." It caused a lot of burning. So I'll come back to that in a little bit. So, he highlights a very challenging issue, which is pruritus. So this is a sensation of itching around the anus. I'm sure many of us have experienced it in some way, shape, or form, which it lasts for maybe 10 minutes, 30 minutes, an hour. But patients who come to see us, who get an appointment, who miss work, who pay for a visit, and who want help, usually it's having a bigger impact on their life. It can affect up to 5% of the general population. It affects men more than women, interestingly. Probably not interestingly, because I'm sure men are not as good about cleanliness and things like that as women are. But there's two main forms. One is primary, one is secondary. With primary, we often don't see etiology. It's thought to be, well, maybe there was some chemical irritant that just led to chronic activation of nerve fibers, and they have this persistent symptoms of itching and irritation. Secondary, is there something there? It's from hemorrhoids, it's from skin tags, it's from a local infection, it's from IBD, it's from something else. Yeah, so anorectal pathology is the ones I had just mentioned. Sometimes hemorrhoids lead to fecal soilage and incontinence, and it can just lead to local irritation. Sometimes treating the hemorrhoids helps. Actually, I literally just saw someone Thursday, and I was doing a second band. He was like, I had seepage for so many years, and someone else banded one during a colonoscopy, and I came to finish in the office. He was like, for 2 weeks, for the first time in years, knew what it felt like to not have seepage. And I felt great. But when he has seepage, he has irritation. So he was a perfect example of hemorrhoids leading to seepage, leading to pruritus. There's something called polished anus syndrome. Some of us watching may be guilty of having some polished anus syndrome. It's aggressive cleansing of soaps of the perianal area with soaps and scents. You want it to be so clean and polished that you kind of dry out the area. You wash away the oils, and then on top of that, just like anywhere else in your body, when you put scents and certain lotions and soaps, you can have a local dermatitis. Dietary factors may play a role, so coffee, similar to what may cause other perianal issues with hemorrhoids and whatnot. Coffee, tea, spicy foods, citrus, tomatoes, chocolates, these all can contribute. So infections can definitely do it. So different fungal infections, bacterial infections, parasitic infections, um, um, and then anal warts, right? So Dr. Krish is going to go over a proper exam of the anorectal area, but the one thing I always, whenever we give these talks, is I always want to throw caution to being aggressive about not missing condyloma. We may be the only people who see that area in their entire life, so we don't want to miss it. Skin conditions, so psoriasis, seborrheic dermatitis, lichen planus. And then there's a few medications that are associated with it, tetracycline, colchicine, quinidine, and neomycin. So just like everything in medicine, history plays a very substantial role, as is physical. A lot of what we do in GI is history and physical. Timeline, toileting behaviors, hygiene, quality, frequency of stools. These all are important questions to ask, like, are they very constipated, and do we have to be aggressive with constipation and treating any anorectal pathology? Do they have diarrhea? Do they have soilage? Do we need to try to find a way to maintain cleanliness of the perianal area without soaps and whatnot? Proper exam, looking for a possible culprit for their pruritus. There is a Washington Hospital Center classification score. This is kind of overkill, but there is a standardized way to actually assess it. And the most severe would be lichenified skin with coarse ridges and ulcerations. This is important mainly because it also shows chronicity, right? So if you see someone who just has really thickened skin, or even some ridges and ulcerations, this has been on for a long time and they've been aggressively dealing with it. So we talked about evaluate. So consider a colonoscopy for luminal pathology that can cause perianal disease. If you have the capabilities to, and there's no obvious external hemorrhoids, then I would recommend anoscopy to evaluate it for hemorrhoids. Although usually if you don't see external hemorrhoids, it's less likely a big driver for your pruritus. But to complete and be thorough, definitely do anoscopy if you have not already done a colonoscopy. And then if symptoms persist despite, multiple different therapies, topical agents, you can consider the perianal biopsy to look for dermatologic conditions or atypical infections. So similar to, again, most perianal issues, fiber supplementation, you want to limit soilage and incontinence. You want to limit dietary offenders, and you want to limit aggressive cleansing with soap, scents, and lotions. So you want to avoid polished anus syndrome. Use plain rinses, either use a jug or a spray or bidet instead of aggressively washing with toilet paper. Looser fitting clothing, airflows, doesn't allow moisture to set in, which can cause infections and irritation. Soothing agents like balneol, which is actually recommended by the college or the Royal College of Surgeons, can be helpful. Do not do long-term steroids more than 1 or 2 weeks. Do not use alcohol wipes, and limit witch hazel. Witch hazel people use for hemorrhoids, which if you want to use it for a few days to a week, that's okay. I guess it's okay. I would not use it long-term. And just being, lifestyle interventions, mild therapies, that can be effective in up to 90% of patients. If it persists, you can do a short course of steroids, like I mentioned, and then transition to a barrier cream. In a quality of life score survey, 3/4 of patients who use hydrocortisone for a week had improved quality of life. Treat the anorectal pathology. If there's concern for infection, if it looks like it may be infected with Candida or something else, you can try an antifungal or antibacterial ointment. Now, if it persists, You can try topical capsaicin, and there was a study looking at capsaicin versus placebo, and 70% of the patients had relief. I always tell patients use a glove because it can burn your skin elsewhere, and you don't want to get in your eye or your mucous membranes. So use a glove and put a perianal area and see if it helps. And then again, if there's persistent symptoms, skin biopsy. And then there was a study looking at methylene blue. And essentially the idea is it'll kind of destroy the nerve endings. Now, in one of the first studies looking at it, there was really good response to treatment, but at higher doses, there have been many reports of necrosis. So if you're going to do it you want to do it at a low dose, and it may be quite helpful, but two, you just caution patients of the risk of necrosis. Just as a treatment algorithm, kind of reviewing what we just went over, eliminate irritants, target perianal pathology. This was low-hanging fruit, short fingernails. You don't scratch so much and cause lichenification. You can use the air dryer to dry the area. Balneol is a very, very good one. You can do a berry cream like Desitin or butt paste because they have a high quantity of zinc oxide, which can help. And then this is just like, reviewing what we just went over. Treat anorectal pathology, fiber supplementation. If it's nocturnal, you can try antihistamine like Benadryl. You can try topical antibacterial, antifungal. If there's any hemorrhoids, treat the hemorrhoids. If there's persistent symptoms, you think about capsaicin, and then methylene blue is last step.
Excellent. That was a great review, Raman. When you went down to details like polished anus syndrome, I knew you meant business with being comprehensive. That's excellent talk. Thank you. Okay, so what I'm going to do now is talk about the examination of the anorectum and also the treatment of hemorrhoids and how you can manage them in your clinic. So I hope you can see my slides. I'm going to talk about examination of the anorectum with digital rectal exam and anoscopy, and then go on to talk about office management of hemorrhoids. So, commonly seen anorectal disease. You see a lot of this. Hemorrhoids and anal fissures comprise the majority of what we see in the outpatient setting. Pruritus, we just heard a comprehensive talk about it, and abscesses, anorectal dyssynergia, which is one of the disorders of defecation, but it really stands alone because you see it so often in patients who have chronic constipation and have been treated by their PCPs, and they've self-treated and they're still constipated, and over half of them will end up having anorectal dyssynergia. And then every now and then you will see fistulae perianally. And of course, most fistulae that you see are not inflammatory bowel disease, but obviously you see a fistula, it's not normal, and you have to investigate further. So training in the treatment of anorectal disease has lagged in the training of gastroenterologists in the US, really, not worldwide, because anorectal disease has always been treated by the gastroenterologist, mostly. So I want to talk about in-office management of anorectal disease and how to perform a good anorectal exam. And it includes inspection, DRE, anoscopy, which is quick and easy, and you can really see it being done on video. And after today, you should be able to do it by yourself. And good to remember that hemorrhoids don't hurt. So if your patient is complaining of pain or you're causing pain, examining them, it's not hemorrhoids. Okay, so this diagram that you see on the right, this is where it all happens. Center of the human body is the sigmoid colon, rectum, I don't know if you can see my arrow, but this is the puborectalis sling that comes in from the pubis, wraps around the distal colon and back into the pubis. So when this contracts, this is pulled forward, and that helps with continence uh, uh, and prevents incontinence. And when it relaxes, that's what happens when you sit on the toilet. This is the external anal sphincter, internal anal sphincter. This is under voluntary control. This is not. And this is the anorectum that goes up to the dentate line. And above the dentate line is where internal hemorrhoids arise from. And below the dentate line is the anoderm, which is somatic sensation. It is where external hemorrhoids happen. And when you have the reason tears are painful is because they involve the anoderm. So we'll just, to give you an idea, in the anatomical position, this is a patient lying on their left side, so the sacrum is on this side. So that's the right posterior hemorrhoid, right anterior, and left lateral. Okay, so I try to avoid saying 10 o'clock and 2 o'clock and 6 o'clock because some people, particularly surgeons, examine them prone. And so if you say go by the time of the clock, it can cause confusion. So try and stick with the anatomical positions of the hemorrhoid columns. So just to give you an idea, when you're doing your anorectal exam, you introduce your finger into the rectum and you get some idea of the resting anal pressure. And as you introduce your finger further in, posteriorly, you will feel the puborectalis, particularly if you tell them to squeeze. You'll feel the anorectal sling push against your finger. This is a drawing I borrowed from from a friend, S.S. Rao, and who has done a lot of research on the mechanisms. So your finger probably isn't this deep in, but the tip of the pulp of your finger would be here. And when you tell them to squeeze, this pushes against your finger. So you know that when you tell them to bear down, this should relax and move away from your finger. And when you tell them to tighten up their sphincter, this will push against your finger. And that is normal physiology. And we'll talk about when it doesn't work. So just to give you some idea of a thorough exam, when you're first look at your patient, look at the anal opening and surrounding skin. You are looking for skin excoriations, skin tags, anal fissures, scars, look for external hemorrhoids. Is the anal opening gaping? Are there hemorrhoids? Are there any that are prolapsing? Any evidence of condyloma? And then the anocutaneous reflex tells you that the pudendal nerve is intact. If you stroke the side of the anal opening, you get a brisk contraction, the so-called anal wink. And it tells you that there's no pudendal damage, and it confirms the integrity of the sacral S2, 3, 4 and motor innervation to the anal sphincter. The digital rectal exam should not be tender. If there's tenderness, there's a problem, usually a tear. And tenderness and tears can be felt also. So when you have a tenderness and a sharp pain, that is a fissure. It can't be anything else. You're looking for masses, strictures, the quality of stool in the rectum, if there is some there, all help in making your diagnosis of what's going on. When you have your finger in the rectum, as you say, you assess the anal tone, the sphincter pressure, effort, and you can feel for sphincter defects in patients who have incontinence, and that's usually confirmed now with EUS. And when you're asking them to bear down, you put your right hand over their belly to get some feel for how much effort they're making in trying to bear down. Okay, and then you're looking for relaxation when they're bearing down, and also some descent of the pelvis. And the pelvis usually descends a couple of centimeters normally, and if it's descending 5 centimeters, that's abnormal. So this is an anoscopy showing you this is patient's posterior is to the left. So this is the left posterior, sorry, the right posterior hemorrhoid, right anterior would be here when you rotate the scope, and left lateral would be down towards the patient's left. And as you pull your anoscope back, you can see the dentate line there. So you clearly want to be up here if you're talking about banding a hemorrhoid. So we'll talk about the details of this as we go along. I'm going to show you a quick video about how anoscopy is done. Very easy. Explain to the patient what you're going to do, lube thoroughly, and gently insert. And as you pull back the trocar, you're seeing this is the right anterior hemorrhoid. We rotated from the left anterior to the right anterior, and now we'll rotate further. And you can only do this with a beveled scope, not a slotted scope. And I'll explain the difference later. And as you pull slowly out, that's the hemorrhoid going away from you. And then you will see the dentate line right there. And you don't want to be anywhere close to the dentate line for any of your therapeutic maneuvers. And we'll look at that. So we've seen that. So hemorrhoids are a big issue. 50% of Americans are symptomatic by the age of 50. So that certainly includes me, but I'm not going to talk about my symptoms. 10 to 20 million Americans have active hemorrhoid disease. That's a lot of work and a lot of business. And a lot of patients keep it to themselves, but when they come to you, they've tried everything over the counter, and it's your purview. You have to examine them and fix them. This is not rocket science. It's easy to do. Your patients spend a lot of money annually on over-the-counter products. The most frequently shoplifted item from a drugstore is preparation H. So they'll start to lock it up like they do the condoms in the future. More than 120,000 hemorrhoidectomies are done every year. And some of these may be unnecessary. And as you will see, the vast majority of hemorrhoid disease can be fixed in the office. So when you send your patient to the surgeon, that's exactly what they do. They band them in the office. And that's what you should be doing. Because banding, as I will show you, it pays more than an EGD, the physician fee. And you're just giving away your business and you're losing patients. So you should really incorporate this into your practice. So hemorrhoids are just enlarged vascular cushions in the anal canal. Everybody has them. They contribute to continence. And most of the time, you'll find them in the left lateral, right anterior, and right posterior positions. The etiology, there are numerous reasons, but the main ones, chronic straining, because we are all constipated, is one. Prolonged lavatory sitting doesn't help because there's no support for your pelvic floor when you're sitting there busy on your iPhone or reading a novel. You're actually making your hemorrhoids worse. Pregnancy, ascites, liver cirrhosis, there's frequently a family history. In pregnancy, you try not to do anything. I try not to do anything because hemorrhoids are common in pregnancy and they're gone after a few months after delivery. So you try to use conservative measures instead of being too aggressive. With patients who have liver cirrhosis and ascites, you want to make sure that you're not confusing rectal varices with hemorrhoids. And varices, of course, go up to the proximal rectum, and the hemorrhoids will not go past a third of the rectum, distal rectum. All right, so this is a little basic, and bear with me, but this is how we divide our hemorrhoids into internal hemorrhoids that arise above the dentate line and external hemorrhoids. Now, the dentate line is not a clear-cut line above which there's no sensation, right? There's a gradient. So just because you put something if you put a band or burn very close to the dentate line, the patient will feel it. So you need to go as far up as possible where the sensation gets less. So any hemorrhoids below the dentate line are external, somatic sensation, painful to cutting or burning or banding. So you can't mess with external hemorrhoids. But most of the time, the natural history of external hemorrhoids is that they become skin tags and they're ignored. That's what skin tags do. They just tag along, as I tell my fellows. So the other way that hemorrhoids are classified is it relies on what the patient tells you. So first degree hemorrhoids are just bleeding only. Patient comes to you and says, well, I noticed some bright red blood on the toilet paper. That's first degree hemorrhoid. Second degrees, they say they feel something protruding, but when they stand up, it goes away. That's second degree hemorrhoids. Third degree is when they say they have to push something back in. Those are hemorrhoids requiring manual reduction. And fourth degree is when they cannot push them back in. So most first, second, and third degree hemorrhoids are fixable in the office. This bears repeating. First, second, and third degree hemorrhoids can be fixed. Now, some bad third degree hemorrhoids and all fourth degree hemorrhoids have to be referred to surgery. So when you look, you have a pretty good idea of what's going on. These are external hemorrhoids, right? Same color as the skin. That's not mucosa. That's external hemorrhoids. Nice, juicy hemorrhoids there. And this, on the other hand, are internal hemorrhoids. They are coming down from inside. If you tell the patient to bear down, they will get bigger and come out a little more. And you may or may not be able to push them back in. Those are reducible. So that makes them a third degree hemorrhoid on the right. All right. Now, this is a patient that came to us, and I took one look at that and I thought, this is a surgery referral. And this patient, who happens to be a physician, said, you know what? I don't want surgery. Do whatever you can. But whatever you can, surgery is my last resort. Just see if you can get them fixed. And so I gently reduce them. They're gone. So these are third degree hemorrhoids. They look like fourth degree, but they're not. And because of the patient's insistence, who's a colleague of ours, I decided I would go and get aggressive. And so we did a sigmoidoscopy, and you can see these are the internal hemorrhoids, there, and there. And this is the external hemorrhoid. And it's important to know this. So there's one line there, which is the dentate line. And there's a second line here. And you don't need to worry about these. You just need to know that your hemorrhoid band needs to be up here, so that if you try to put your band over here, you're just going to suck this into your band, and the patient will be uncomfortable afterwards. So just not to split hairs, but the dentate line is here, and the anorectal line is here, and this is a transition zone, and your sensation decreases as you move away from the dentate line. And that is why you really need to band as far away as you can, because even when you suction the mucosa here, you will pull this line up to your band. So with this lady, we banded her with a sigmoidoscope, with an upper scope at sigmoidoscopy. And the reason we did that and not did office banding was because the variceal bands are bigger, and we knew we wanted to be aggressive here and get as much mucosa as we could. And we brought her in and banded her on 3 different occasions, which is 2 bands at a time, 6 bands. And her hemorrhoids have settled, and she's delighted that they don't prolapse anymore and they're not symptomatic. So it just goes to show that grade 3 hemorrhoids are fixable in most situations. I showed you an extreme example, but I wanted to make a point. So the importance of careful examination of your patient is this. If you miss anything in your hurry to do a screening colonoscopy even, you're responsible medico-legally, right? Here is a small anal cancer. Now you can see in a dark room, you could easily miss that when you're getting ready to start your colonoscopy. So if you do your rectal exam and you feel, first you inspect, before you put your scope in, use your scope light to look. Then examine digital rectal exam. If you feel anything firm or uneven, look at it and take it seriously, send it to the surgeon. That's what I will do if I'm not sure about something. They can biopsy it and get a diagnosis. This is an obvious example of an anal condyloma, but they're not always this obvious. But if they're this obvious, you should wear gloves if you don't normally. But look at this. Easily missed. These are anal condylomas, and they may not even be this obvious. You may just have 1 or 2. And if this patient develops anal cancer down the road, it could be an issue for you. This slide just showing where your external hemorrhoids end. So when you look at hemorrhoids on sigmoidoscopy, you're pushing the external hemorrhoids into, and so these are external hemorrhoids. So when you try to, this patient really does not have internal hemorrhoids, which would be up here, bulging upwards this way. So important to make the difference. I've seen people put bands on hemorrhoids just because they see them on the inside. Well, most times they're external, and your patient wakes up very displeased. So a few more photos. This is internal hemorrhoids coming down and prolapsing out a little bit. And this is an external hemorrhoid, right? This is a thrombosed external hemorrhoid. Now, these will become skin tags over time, right? They get reabsorbed and they're left as skin tags. So sometimes it's a cosmetic thing, particularly with young women. They'll say, oh, I don't want this. It's just, I need it gone. And then you can send these people to a surgeon to have that removed. And it's technically not a hemorrhoidectomy. You're getting rid of this cosmetic nuisance. This, on the other hand, is an incarcerated 4th-degree hemorrhoid. You cannot release it. Patients in pain. You need to send these. This needs surgical intervention promptly. So management of hemorrhoids is really quite straightforward, right? For most hemorrhoids, fluids, fiber, at least 20 grams a day. And when you ask people to go take Miralax, get Metamucil, and they go buy some capsules, that's not nearly enough. They need at least a tablespoon of Miralax, Metamucil powder, which is about 17 grams a day is the recommended intake, and drink that every day. And I tell them it's just like eating a salad, but since I hate salads, this Miralax is very doable. And if you do that, and between Miralax, Metamucil, and stool softeners, you can overcome the majority of constipation, and you don't need more expensive prescription laxatives. In fact, by far the majority of constipation can be taken care of with over-the-counter intervention. They can use Preparation H. Steroid suppositories, if you have to use them sparingly, just a week's course if their hemorrhoids are really playing up, and not more than maybe once or twice a year, because it does soften the skin. It makes it thinner and more likely that you will have itching and other complications. Preparation H is safer, and a lot of people use that anyway. Limiting time on the commode is a big deal, especially now that we have smartphones. And so don't take your smartphone into your toilet unless you can set an alarm for 5 minutes when you'll get up. But chances are you'll be so deeply involved in your Facebook arguments with friends that you'll easily pass the time, especially if you can charge your phone while you're in there. So that's my diagram for what happens when you take your smartphone into the toilet. And you shouldn't be reading novels either, because time flies when you're having fun. So the other way to reduce the pressure in the lower pelvis when you are straining is to have your knees above your hips. So when you're flexed, the anorectal angle is straighter. And so gravity helps. So we evolved to move our bowels squatting and not sitting on chair-like equipment. And so you can see here, when you're sitting on the toilet, you have to push your stool around this angle. But when you are squatting, so stick something under your feet. You don't have to spend money buying a squatty potty. Just put your Gray's Anatomy and Guyton's Physiology down on the floor, and that's free. And it will help get the stool out easily. Okay, so what about non-operative treatment options? The most popular and commonly used are rubber band ligation and infrared coagulation. So we make it a point to train our fellows to do both, to use both. Bipolar diathermy, injection sclerotherapy. Well, bipolar therapy is available. Injection sclerotherapy is really less popular, and cryotherapy is a little messy. And so rubber band ligation is probably the most effective, followed by infrared coagulation. So rubber band ligation relies on the tight encirclement of redundant tissue, the hemorrhoid complex, at least 2 centimeters above the dentate line. And I'll show you how it's done and what happens and why it works. There are lots of banding devices out there. I just put 3 photos up here, and it's really a matter of personal choice. I tend to use the Oregon because that is what I learned on, but that, again, as I said, is a personal choice what you want to use. But all devices involve suctioning up the hemorrhoid, the internal hemorrhoid, onto a device and then releasing a band over it. And that's how you band. It's easily done. What you want to do is make sure you're way above the dentate line. And this, in fact, is too close to the dentate line, if you ask me, that star. So this is a small video I'm showing of how I do this. Here I am going into the anal canal with my banding device. And once I've gone in, I pull it back to a mark on the syringe that shows me where I am, where the tip is, which is 2 centimeters above the dentate line. So now I tilted the syringe to point towards the right posterior hemorrhoid, right, which will be up here. And the right anterior is here and the left. So now I'm pulling in the right posterior hemorrhoid. I've now suctioned it and locked my syringe. And now I am rotating the syringe just to make sure there's no pinching that the patient feels, which means I'd be too low. Now I'm slowly pulling the syringe back from the oversheath, and that releases the band onto the hemorrhoid. And that is it. Now, more important than that is doing a rectal exam to make sure that you don't have too much hemorrhoid, too much tissue. Otherwise, your patient will complain. And I will show you a short cartoon, but what I'm trying to do there is make sure that the hemorrhoid is easily mobile, like a polyp on a stalk, easily mobile and not stuck down, which means I have too much wall in the hemorrhoid, in the band. And this is a cartoon showing what I'm trying to do here. And if you see here, you've got the muscularis, and you need to get that out. And just by massaging your hemorrhoid gently with your finger, always with a glove on, you can get this to come down, and then your patient will not feel any discomfort. And particularly if they're having discomfort, make sure you go in and loosen that to get the deeper layers out of your band. You're only interested in the mucosa, which is where the hemorrhoid is, right? So there you have it. Okay, so what happens is you put the band on, you get ischemic necrosis, and the tissue sloughs off. You get an ulcer there, and the ulcer heals with fibrosis, and that does two things. It tacks the mucosa to the back, to the wall of the rectum, so that you don't get prolapse. And it cuts off the blood supply coming into the internal hemorrhoid, right? So it works very effectively. You can see that you've made a ring of fibrosis. And so the hemorrhoids shrink, and the mucosa cannot prolapse because it's fixed. Now, so the complications, about 5 to 10% of patients have some discomfort, and they describe it like a desire to go to the bathroom, an urge to move their bowels. And it's not a bowel movement, it's just the reaction to the band. Usually they take Tylenol, Motrin, or sit in a sitz bath, and those that have to, the majority don't need anything. Now, the things to be aware of are there are complications. You can have abscess, urinary retention, band slippage, or bleeding. They can occur, and you tell your patient to come back if there's any issues. And we give them instructions in writing describing what to look for. So a very rare complication is necrotizing pelvic sepsis. This can be lethal, and I have heard of at least one death from a case that was mismanaged. But we tell patients that when they leave the clinic, they are mostly symptom-free. If over the next couple of weeks they develop severe pain or bleeding that won't quit, or a high fever, or urinary retention, or any combination of those, they come to the ER immediately, where we are called to aggressively deal with the patient. This should be your plan if you are doing hemorrhoid banding. So if your patient, you've just put a band on and they're complaining of 6/10 pain, well, that's too high. Usually your discomfort shouldn't be more than a 2 to 3/10. Okay. So the possibilities are that you're on or below the dentate line, in which case you remove the band straight away and patient will be happier. Or you've got too much trapped into the band, and as we showed, you have to examine them and make sure that you don't have too much wall caught within your band. All right. And just to make a point, some of us the patient comes in for a screening colon, they whine about their hemorrhoids, and they give you permission to do something, anything, band them if you can. And I need to show you this video because sometimes you'll end up banding, and you have to change scopes to an upper scope, right? Because the banding device won't fit a colonoscope. And so we tell the nurses to bring the upper scope. You go into the rectum, retroflex. If you're going to band, you tell them to load the upper scope while you get to the cecum. But I want to show you this just to drive the point home, the mistake we make. These are external hemorrhoids, and you can see the dentate line, right? You don't want to be anywhere close to it. So I'm saying come way up here. They're the external hemorrhoids. You want to be here. The internal hemorrhoids are not obvious, but they're there because there was too much air when I just showed you this. And so there is one band, and I will make sure that I'm nowhere near the dentate line. See that? Dentate line is down here. So be very careful. Dentate line and banded polyp. You should not be anywhere near the dentate line. And if you are, take it off and put it back on. And the reason is that they're asleep, so you have to be very precise. Now, if I do a flex sig on a patient to band, I don't sedate them because it's a lot more, it's quicker and more accurate because you suction the hemorrhoid in, you ask them if it hurts. If it doesn't, you band it, and you know you're in the right place. So if you're going to do a flex sig with banding, do it unsedated. All right. And basically, this is just pointing out that you have to be as far away from the dentate line as you can. And this brings us to the next mode of action for hemorrhoid treatment, and this is infrared coagulation. And some people will say, well, I've looked at this laser treatment for hemorrhoids. And laser is not really a laser, obviously. It's infrared coagulation, which uses heat to treat hemorrhoids. And this focuses energy from a tungsten halogen lamp. And I'll show you, this is done under direct vision. You look at the hemorrhoid, you go past it, you press into the mucosa with your probe, and then you pull a trigger that burns, that cauterizes the mucosa. And you do that in about 5 or 6 different places, just proximal to the hemorrhoid, the internal hemorrhoid column. And that, it also causes fibrosis and reduces blood flow, and it works. I use it mostly for patients who are on anticoagulation, because remember, they bleed when the band falls off, not when you put the band on. So there's no point stopping their Plavix or Coumadin on the day of your banding, because that's not when they're going to bleed. I use it in pregnant women if they insist that we do something, because when you put a band on a pregnant woman, and if she starts to complain of lower abdominal pain or discomfort, you get a call from the OB person who is concerned about preterm labor and all that. And it's best to just use suppositories and steroid ointments and sitz baths and roughage and keep the stool soft in pregnant women until after delivery. But if you have to do something, do IRC, not banding. Now, there are some young patients with severe IBS who will not tolerate banding. They hurt more. For whatever reason it is, either that they have always had chronic pain syndromes, or that they're just very sensitive. If you put a band on, I always explain to them, if they have gas, bloating, constipation, or a history of IBS, I say, patients' bowels are more sensitive to banding. And if you would prefer, although banding is better, IRC might be more appropriate for you. But if you wish, we can try one band and see how you do. And if it's not tolerated, you go to IRC or you start with IRC. And this is the business equipment that you have to have. And there's a bulb in here that produces light. And this is the tip that gets extremely hot. And this dial here sets the time. So usually 1 second is more than enough to create a burn in the mucosa. So you rotate the dial to set the time, and there's a trigger here. You pull that back, and it will only fire for that amount of time, and that switch off. And as I said, it's under direct vision. So you go through the anoscope to the proximal hemorrhoid column and press against the mucosa and pull the trigger. And you want to do that in several different locations, feeding the hemorrhoid so that you get the vessels feeding the hemorrhoid. Okay, so this is a video one of my fellows helped record, and here I am doing infrared coagulation. And as you will see, you get a white cautery mark, and I'm going 5 or 6 different places. And I don't know if you can see that, but you see those white marks is where they're burned. And the patient doesn't feel this. If the patient feels a burn, it means you are putting too much energy in there and you have to dial down the time of the burning. So very easy to do. And you do that for all three hemorrhoids at the same setting. And if the hemorrhoid symptoms are particularly bad, I'll bring them back in a couple of weeks and do the same thing again. All right. So rubber band ligation seems to give better, longer lasting results. Uh, from personal experience, if patients are going to come back to you, they come back 5 years later for rebanding or 3 years later for IRC repeat. Okay. So that's my experience, no studies, but that seems to be it. And when they have surgery, if they're going to come back, it's 10 years after surgery, their hemorrhoid symptoms recur. But I tell them all, if they're careful with their diet and toilet habits, their hemorrhoids may never come back. But there's no cure for hemorrhoids. It's like heartburn. You have to watch what you're doing. We can fix them, but it's not a permanent fix. And as we just said, pregnant women, patients on anticoagulation, and significant IBS symptoms are maybe better candidates for IRC. So no discussion is complete without talking about thrombosed hemorrhoids, which happen, right? The patient is doing their usual thing. Suddenly they get severe pain in their anal area that won't go away. They can't sit, they can't walk properly. It is just unbearable, and they come to your clinic walking funny. And it's usually that an external hemorrhoid has clotted. It's tense, it's painful, and it is very easy to fix. And your patient is delighted because you fixed them. And most ERs are well equipped to do this. They'll just lance this, get the clot out, and send you off. Well, they'll probably do a belly CT too, but that's just life. And so thrombosed hemorrhoids present with acute pain, and what patients usually say is like a golf ball mass that suddenly appear, associated with heavy lifting, straining, sitting. Chronic diarrhea can also do it. You get a lot of anal spasm when this happens, and that's part of the discomfort too. And usually, if they come to you a week after the onset of symptoms, treatment is symptomatic and it's conservative. You treat them: warm baths, stool softeners, lidocaine ointment, nitroglycerin or calcium channel blocker ointment for the spasm. And you just, in a couple of weeks, it'll settle down and slowly it'll get less painful. But these people have hemorrhoids. So after everything settled down, you bring them, do an anoscopy, and band them so that this doesn't happen again. Now, if patients come to you within 72 hours, then you should do an incision and drainage. And this is my kit that my MAs know where it's kept. And so I need lidocaine, a scalpel, syringe, TB needle, the tiny, thinnest needle you can find, scissors, and clamps. And it's very easy to fix. This is a pregnant woman who presented with a thrombosed hemorrhoid, third trimester. So I'm injecting her thrombosed hemorrhoid. This is the only part she felt. And after that, the rest is painless. And she left the clinic pain-free. So here I'm cutting into the external hemorrhoid. Usually by now, the clot will pop out. It's under pressure. And I think she may have gone past her 72 hours. But so I have to dig a little deeper. But there's the hemorrhoid. You don't want this to close and the hemorrhoid to form again. So you have to de-roof this. So if you leave it open by removing one side of it, and that's what I'm doing now, you just cut off one side and then it stays open. And it will not bleed, and the patient is goes into the sunset happily ever after. And that's it, fixed, and it takes literally about 3-4 minutes. And you should all be able to do this in your office if the patient shows up acutely. If you tell them, oh, we'll arrange for you to go see a surgeon, well, they'll go past their 72 hours and there's nothing left to do, right? So you perform a good anorectal exam with a history and you will get the diagnosis almost always. In-office treatment for hemorrhoids is safe and effective. Patients need, and very few patients need surgical intervention. About 20% of the time, anal fissures and hemorrhoids coexist. And so it's important to make sure that you examine them first when you do a digital rectal exam. And if they have sharp pain, they have a tear, you treat that first. So then you send them off with their lidocaine and nifedipine ointment or diltiazem ointment and give them 6 weeks. Let that heal before you go in with your anoscope, because it's quite painful to try and do an anoscopy on somebody that you know has anal fissure. So just do the fissure treatment, let it heal, then address the hemorrhoids. If you need to read something to help you sleep, I have put some of my publications at the risk of self-promotion. And there's always something interesting in the colon. Last week, we found this, and I thought I'd throw that in, although it has nothing to do with hemorrhoids whatsoever. But this gentleman probably did a lot of hunting and camping and drinking spring water and had these floating around. Oh, all right. So that was my thing on office management of hemorrhoids. And later on, I'll talk to you about setting up your own anorectal clinic. Let me just see what the questions are. How to manage urinary retention. Well, if a patient that you band gets urinary retention, that can be a very serious sign that they have pelvic sepsis. So the urinary retention is a sign that you need to jump on this patient and treat them aggressively. So you bring them to the ER, inform surgery, do a pelvic MRI, do their vital signs, obviously, the temperature, white count, pelvic MRI, get a general or colorectal surgeon to examine them, because that's the main thing you want to avoid, urinary retention. It shouldn't really happen just from banding alone, but it is not uncommon when there is pelvic sepsis. So that is what would alert me more than just regular urinary retention. It is pelvic infection until proven otherwise. I hope that answered that. And then there's another question that says, have you any thoughts on Hamwell electrolytic coagulation of hemorrhoids? Now, I have to admit, I'm not aware of, is this an electric current coagulation? Because if it is, then it sort of serves the same purpose as the very similar to the IRC. Then somebody's asking, do you get paid for IR? Yes, of course you do. I wish I could give you an RVU number or a value for it, but yes, it's an in-office procedure. And once you've done that, and I will ask I know this person who's asking this question, and I will get back to you with exactly how much the Medicare rates are. But of course, it is a procedure that you bill for. And let's see. What would you use to remove the band if placed too close to the dented line? That's an excellent question, because very often you have to. Now, 9 times out of 10, I just use my fingernail to push the hemorrhoid up towards the tip of the banded mucosa, and it comes off. Okay, so that works most of the time. If that does not work, you can do it under direct vision. You put an anoscope in, look at the band, and you can either cut it with a scalpel or with scissors. So that would be the other way to do it. Okay, so it's usually easy to take that off, but hopefully you don't have to. It's a pain, and if you have a lady with bad IBS who is complaining of pain and wants her band removed, it's difficult to just get access to the band because they're so tense and writhing around. But normally, you calm them down, tell them what they are going to do, and you can do it just with your finger. You can remove the band most of the time. Any issues with insurance not covering banding? I have never had an insurance company not covering the banding. Although, my office always clears insurance coverage. It is Medicare approved. It's about $270 through is the payment for Medicare, and obviously for private insurances, you bill more and you get what you get. I think that is the extent of the questions. If there's any other question, please let me know. Oh, I'm sorry. There's more. Do you recommend anoscopy prior to? Absolutely, prior to banding. Now, I only anoscope once, okay, because I always band the right posterior first, and I go clockwise. So when they come back the next time, I've already banded the right posterior. There's no point looking at it. You'll most likely just see an ulcer there. It doesn't tell you what the final result is going to look like. So when they come the next time I visit, I band the right anterior, and 2 weeks after that, I band the left lateral, and that's it. So, and I tell them there's no follow-up unless they have symptoms. And now that's my practice, but you can always bring them back and take a look with your anoscope and have a clinic visit and talk about their symptoms. But yeah, I anoscope once and look at, unless they are complaining of symptoms or they come in and say, oh, I think I saw my band, it fell off. Now that's quite rare for a band to fall off within a day or two. But if they say that, then you have to look, and then anoscopy is required. Okay, let me go to. I find that excess fiber supplements give harder stool. Yeah, now that's a good point. You have to use soluble fiber, and Metamucil is good. If you use the capsules, you have to make sure you drink enough water. And if you buy the Metamucil, it will say to dissolve a capful or a tablespoon in a large glass of water. So a lot of times people are chronically dehydrated. They will put it just in a small cup and try to get the whole thing down. You have to have the fluid to go down with it. Now you can overdo fiber, and then you get bloating and so on. But soluble fiber, such as psyllium, is what is recommended to keep your stools regular. And if that's not doing enough, you can always add some Miralax. It says, and my next question, can you develop anemia from hemorrhoid bleeding? And patients will say that, of course, and it is possible, but it's not commonly the presentation. So you always assume that it's coming from somewhere else until you cannot prove that. So you you have to do a pan endoscopy. You have to do the iron studies, the colonoscopy, and upper, and a small bowel capsule if you haven't found a source of bleeding. So I always assume that iron deficiency anemia is from a sinister cause and not just from hemorrhoids, because it's hard to get anemic just from hemorrhoidal bleeding. But that's my experience. So, and medical legally, it's sound for that to be your diagnosis of exclusion, where you've looked at the upper and lower and small bowel before you blame it on the hemorrhoids. And to be honest, even if I fix the hemorrhoids, iron deficiency anemia is a serious presentation for something bad going on. So I would always do pan endoscopy before or during the banding, because seeing blood is distressing, and if they have bands, they need to be fixed. If they have hemorrhoids, they need to be banded, but you need to assume that there's something more going on. Now, with Flex Sig, there's a question here that says, is the reimbursement the same for in-office banding and Flex Sig banding? And, for Flex Sig, I have to go to the endo lab. So there's the facility fee, and there is the cost of the banding device, which is about $400. Now, so, the physician fee remains the same. The physician fee is not, so is the facility fee that covers the cost of the banding device. Otherwise, you'd be losing money. If I could do a Flex Sig in the office, I wouldn't do it because I'd be losing money. Now, I'm in an academic setting, so I'm just saying this in a theoretical sense. But so no, office banding is where the physician fee is significant and there's very little cost. The disposable anoscope is about $5-6. I use the built-in light ones. They're so easy to use, and they're one-time use. And then the banding device can cost anything from $30 or $40 to $70 each. And you can do a banding in less. You can see patients in 15-minute blocks or less if you have a well-organized team. So we have a half day when we do about 10 bandings, and we give it slots because we teach our fellows how to do them, and then they do them. So we allow time for that. But no, you can do a whole bunch of banding in a half day or one day in 15 or 10-minute slots, and you do good. So the answer to that is they're really two different situations. Flex Sig is in the endo lab. There's facility fee involved, and that has to cover the cost of your bander and all that stuff. But in the office, you're not using anything but a banding device. There's no sedation, there's nothing. All right. Do you require colonoscopy prior to banding? Let me say this. I have a much lower threshold for doing colonoscopies in patients with rectal bleeding, since so many younger people are showing up with colon cancer. So absolutely, unless I have a teenager showing up with rectal bleeding and constipation, I will always do a full colonoscopy, unless they've already had one. So very often they had one a couple of years ago, in which case you're fine. You just go and do the banding. But otherwise, you always do a full colonoscopy. Never assume that the bright red blood is from hemorrhoids. Because even if it is, colon cancer is common, and they could have colon cancer as well. Okay, and then a question, is there any consideration for training advanced practitioners in addition to fellows to do this procedure for the office setting. You know, there are offices where that is done, and it really depends on your on how you want to run your office. Absolutely, there are offices where the advanced practitioner provider is banding, and you know, so there are offices where they do all the banding because the gastroenterologist is too busy doing other things. But that's really up to your individual office and setup. And I have somebody here who told us very useful information that the RVUs for IRC 1.61 RVUs with a CPT code of 46930. And just so that you know. And again, you know, these procedures, they are quick. The majority of patients, I probably do about 2 or 3 IRCs a month, and the rest is all banding. But I just think that you should have the capability to provide both, if you can. All right, I think that we had 15 questions. Oh, do you manage post-banding bleeding? Well, now there shouldn't be any bleeding post-banding. But if there is, if you have put a band on and the patient starts to bleed, well, that is your problem, right? They have to come back to you and you have to scope them and see where the blood is coming from. It is uncommon, but you can get bleeding. It's one of the complications. Either the band falls off prematurely or for whatever reason they have a bleed. Well, you need to scope them and clip or cauterize or whatever for that band site. Okay. Now, there's a question here that says, how do you justify to get approval for colonoscopy from insurance for intractable pruritus if patient is not in the age group for screening? That is a great question. Now, sometimes if you have a large villus adenoma in your rectum, the secretions that come out or surround the anal opening can cause pruritus. So for anorectal symptoms, I would call this would be a diagnostic, not a screening colonoscopy. So you check their CBC, make sure they're not anemic. Sometimes young female patients particularly are anemic really because of their periods and not necessarily because of their GI symptoms. But it makes it easier to get your diagnostic colonoscopy. But this is not, as you say, this is not screening. So if they have a strong family history of colon cancer and they're approaching the age of screening, you can make a case for doing a screening so they don't get billed for a diagnostic procedure. But otherwise, I would say a diagnostic procedure to make sure that there's nothing going on further up. Okay, and I think those are our questions. Oh, sorry, more. Is there a maximum number of bands you would do on a patient? Well, for the clinic setting, I try to do 1 band per patient. And if they're having a colonoscopy and they're sedated, I will do 2 bands and give them Toradol IV during the procedure. And you know, the reason is that I try not to do all 3 bands. 1, because of patient comfort levels. They're more likely to be more symptomatic if you put 3 bands on. And secondly, and this has not been shown, but it is possible that the risk of pelvic sepsis might be higher if you just band all 3 hemorrhoids at one time. That has not been shown, but if you were unlucky enough to have somebody have pelvic sepsis, there are a lot of so-called expert witnesses that will come and say, why did you find it necessary to band all three? So we just don't have enough in the literature to studies to show that it is safe to band all three. And so, particularly in the clinic where they're awake, they drive in and they walk out, I do one band and everything goes well. So it's one band every 3 weeks, one band every 2 weeks, so that in 6 weeks, I tell them at the very beginning that they will have 3 visits and then they're done. Okay. And I'm going to also provide the procedure code for banding in my lecture at the end, which is the setting up the anorectal clinic. It says, how do we go about incorporating anoscopy and banding in our practice without prior training? You know, this is a good question, and there are some companies that will come and train you in your practice. And I happen to know that the CRH company is one that does that. There are others. And they will get you to line up 6, 8, 10 patients on a particular half day. And one of their surgeons will fly over and do the first, it seems like they're licensed everywhere in most states. So they'll come and do the first 3 or 4 and then watch you do the rest. And that is one way of doing it. The other is, also attending workshops at the national meetings, although that is less satisfactory. And we have 15 fellows here, and they all want to learn how to do banding. And so, unfortunately, we can't have a course, a hands-on course. But yes, that is, anoscopy is really very easy to do. And even if you get a few anoscopes, just call a company that sells anoscopes and say you want half a dozen disposable scopes to try before you order them. And they'll send them to you. So do the banding companies. They'll send you devices that you can try. But anoscopy, you're not going to hurt the patient, hopefully. And it's easy to do. It's really easy to do, as you saw in that. So with my fellows, I do one, and then I say, oh, here's the anoscope, take a look and show me. And they almost all do the anoscopy right the first time. So anoscopy is not a problem. The banding device, there's certainly a learning curve. And one way is to get somebody from their company that to fly over and show you how to do it. All right. When is it typical for a band to fall off? You know, I usually think about it's the band is never there when I see them in 2 weeks. And it's usually between 5 and 7 days the band will fall off. Usually the patients don't see it. They're tiny, as you know. So between 5, and sometimes they will see a small amount of blood when the band falls off, and that's the only sign that the band's gone. Okay, I have one person here saying CRH wants to sign a long-term contract to buy the banding kits in return for the training. Okay, so this must be something new that they have started, because I know it wasn't there before, and I'll try and, so that comes down to perhaps you're doing the math and seeing if it's worth signing the contract, how long it's for, and what is the outlay compared to some other device that you could save money on, but not get the training. So that this is something where you might sit and have to do the math and see, well, how much money does this involve now, and is it worth your while? But when this wasn't the case with them, and I know them, I'll certainly try to find out what they're thinking and how they come about doing this. Okay, and please send me an email. This is Dr. Messia. Send me an email, if you will, later in a few days, and I'll try to find out. Do you recommend anoscopy prior to each banding? And we address that too. Yeah, no, we don't. I do it once. Remember that they don't pay you extra for doing the anoscopy. It's bundled with the payment for the banding. So I don't see the point of doing an anoscopy every visit. It's just a waste of money and time. Any reason not to use bevel scopes? Is that your preferred? Absolutely. So in my session on opening your clinic, I'll show you different types of scopes. So the bevel scope is preferred because it's slanting, right? So you just you can rotate it without causing any damage. With the slotted anoscope, the hemorrhoid bulges into the slot, into the lumen of your anoscope. So if you rotate it, you can cause trauma. We want to hear about surgical options for hemorrhoid management. And we have the privilege of having one of my favorite, if not my most favorite, colorectal surgeon here at Baylor, Yersinia, who is in the ICU working today. Ouch.
Yes. Good morning.
Thank you for your time and agreeing to do this. And so we want to hear about the surgical options for anorectal manometry. Sorry, I need some coffee. Surgical options for hemorrhoids.
Absolutely. I'm gonna go ahead and share my screen. Are you able to hear me okay?
I can, yes. Yes.
Okay, great. I hope you can see my presentation here.
Yep.
All right, perfect. All right, so I'm going to be covering the surgical management of hemorrhoids and the treatment of anal fissures. Some of them which can be procedures that are done in clinic and others that may need eventually surgery. So the objectives are going to be to describe the indications for the surgical management of hemorrhoids, describe the different types of surgical methods that we have available for hemorrhoids. We'll talk about post-operative complication, expectation, long-term results, which I think are important for everyone to know, and not just the surgeon, because if there are alternatives that you can offer in clinic that are better, or for patients that don't want to take the risk of surgery, then I think that's always an opportunity to do them in your clinic before referring to the surgeon. And then non-healing and chronic anal fissures, we'll talk about treatments for those. So the incidence, and you've already mentioned a lot of this, the incidence of symptomatic hemorrhoids is really difficult to know because there are so many symptoms that can be attributed to hemorrhoids. So a lot of patients come to clinic with already a diagnosis of hemorrhoids. A lot of patients self-diagnose the problem as hemorrhoids, and it's not necessarily the hemorrhoids that are causing those symptoms. So we don't really know what the incidence is of symptomatic hemorrhoids because the presentation is so varied. And again, a lot of it can be self-diagnosis. What we do know is that 50% of people over the age of 50 can present with at least one episode of symptomatic hemorrhoids during their entire life. And in 2004, the NIH reported that the diagnosis of hemorrhoid was associated with 3.2 million ambulatory care visits. That's a lot of visits and a lot of hospitalization. And, the prescription rate, or the amount of prescriptions in the US for hemorrhoid complaints is up to 2 million. So there are definitely a lot of profit that can be made with just with the symptomatic hemorrhoids and hemorrhoid complaints. Now, from a surgery standpoint, we really only see about 1% of those patients that develop hemorrhoids or have issues with hemorrhoids. And, there is a staging that's based on the degree of clinical prolapse. And I think this is important for us to, whenever we assess the patient and evaluate the patient in clinic, to really try to stick to the staging. It helps improve the communication between the surgeon and the gastroenterologist, as well as the primary care physician, who is often the first one to deal with these complaints. But it also helps us not only standardize the presentation of the patient, but determine when the symptoms or at least the physical exam is progressing or getting worse. However, despite the staging, it addresses the degree of prolapse and whether it prolapse with defecation, whereas patients with stage 4, for example, have prolapse that is not reducible after the bowel movement. But it doesn't address the symptoms of what the patient may have. And those complaints can be pain, bleeding, or thrombosis, or even perianal itching or difficulty with hygiene. So it is always important also to get a clear understanding of what exactly it is that bothers the patient, because surgery or whatever intervention that we do may not necessarily address that complaint. So it's not all about the degree of prolapse. So the indications for operative management are those who have failed medical management or in-office procedures, recurrent or persistent symptoms that are ongoing despite the procedures that we offer for internal hemorrhoids, patients who have a large burden or advanced disease, so those who have grade 4, chronically prolapsed hemorrhoids, or in those and who they may not necessarily present with pain or bleeding, but have difficulty in hygiene or have perianal itching because of that difficulty with hygiene. And this is about 5% of patients ultimately need surgery. And then there are special scenarios where an intervention is necessary despite any prior treatment. And those are going to be patients who present with acutely thrombosed hemorrhoids or those that come in with strangulated and gangrenous hemorrhoids. As far as the operative management, the excisional hemorrhoidectomy really is a standard of care. And I'll go briefly over each of them and potential complications. Other options are stapler hemorrhoidectomy, hemorrhoidopexy, although these have kind of fallen out of favor. And I would say that the next one in line would be the transanal hemorrhoidal dearterialization, which is essentially a ligation of the hemorrhoidal pedicle, but is done with ultrasound guidance. The excisional hemorrhoidectomy, which is usually my preferred to go, unless the patient really there's a strict contraindication to excising the hemorrhoid, is the excisional hemorrhoidectomy. And this is really the gold standard. It has excellent results, minimal recurrence rates. We tell patients the risk of a recurrence after a hemorrhoidectomy is probably less than 5%. So, and pretty low complication rates. This was first described in the 1950s by Dr. Ferguson in the Ferguson Clinic, and it still remains the most common operation for hemorrhoids in the US. And as I mentioned, this is probably the to-go to surgery for most colorectal surgeons. And essentially what we do in this procedure is while the patient is asleep, under general anesthesia with the retractor in place, we lift up the hemorrhoid column and we excise the hemorrhoid pedicle off of the sphincter muscle. And this can either be done with scissors, with a knife, or with energy devices. My preference is with the knife, with a blade, to peel off the sphincter muscles off of the hemorrhoid pedicle. And then it's excised and that pedicle is ligated off for hemostasis. And then you can see here I use typically chromic suture because it absorbs pretty quickly and is the least likely to scar. And then we approximate the mucosa and the skin in a locking fashion until we end up with the closure here. And it's usually done in a running fashion. This almost looks like it's interrupted, but really it's running. And so nothing is left open. The incision is completely closed. And then we can do up to 3 hemorrhoid excisions at a time. All of it really depends on how much excess skin the patient has or how much anoderm there is. And we always do this with the anal retractor in place so that we know not to remove too much and thus put the patient at risk for anal canal stenosis. As I mentioned, the results of excisional hemorrhoidectomy are great. The recurrence rate is less than 5% because we're actually removing the hemorrhoid pedicle. Now, while we tend to think that we have about 3 hemorrhoid pedicles, we may have more than that, and some of them just kind of are continuous circumferentially. So it is really impossible to remove all of the hemorrhoid without probably causing problems or stricturing the anal canal. But for the most part, I think we are able to remove a lot of the hemorrhoid tissue to prevent recurrences. The long-term relief, longitudinal studies have shown very little need for any further treatment afterwards. The biggest thing about an excisional hemorrhoidectomy is that the post-operative pain is significant. And when I'm counseling patients about surgery, I tell them that this is the most painful surgery that we do. And that area is very sensitive. They're going to have cuts on the anus that they're going to have bowel movements through. About 30% of these wounds will open up and essentially create anal fissures, which are very painful. And it can take weeks for them to feel like they're back to normal or everything has completely healed. So there is a lot of counseling that goes in place preoperatively and to prepare the patient as far as the expectations of their recovery and what surgery is going to look like. Now, what I do tell patients is that, they're pretty much paying upfront with respect to the pain. And this is because the long-term outcome is so good. So if the hemorrhoid problem that they're experiencing is something that is recurrent, affecting their quality of life, then I do typically recommend surgery. This is one of those procedures that I really defer to the patients to decide whether they want to move forward or not, because it really is a very personal decision and only they know what their quality of life is like with their current symptoms. I think the majority of the patients, when they come to see me, are probably at the end of that and are very ready to move forward with surgery. Now, for the post-operative pain, we have a very strict bowel regimen and pain medicine regimen that we have patients on. But there are also adjuncts that we can offer, like topical nitroglycerin. We can do Botox injections. There is literature out there to support that a short course of oral antibiotics can help with the pain as well. So there are things that we can do to help our patients get through that really bad post-operative period with pain. As far as actual complications, because we don't consider post-operative pain a complication, the most common is going to be urinary retention. Usually this is related to pain control and fluid restriction intraoperatively. So these are things that we discuss with our anesthesiologists in the operating room. Post-operative hemorrhage is less than 1%. Usually this is attributed to a technical error. So if we don't ligate that hemorrhoidal pedicle well, or if the suture falls off, this can also happen. Most of these patients, when they do hemorrhage, they hemorrhage a lot. So this is a patient that needs to come back to the emergency room, typically gets admitted, gets a transfusion, and they go back to the operating room to examine. Anal canal stenosis, this is when we get too aggressive with the excision of the hemorrhoids and we remove too much anoderm during the hemorrhoidectomy. Typically, the way I avoid this is that if I cannot excise the hemorrhoid safely and bring the tissue together with the anal retractor in place, then I don't excise anymore. And in general, the anal canal stenosis, or the anal, it's not the anal canal that's actually stenosis, it's just the stricture at the level of the anoderm. And if we need to, we can always help patients with, show them how to self-dilate or release the stricture. And most often that is all the extent of the complication that we have to deal with. Post-operative infection is the most feared, but the risk of that is really less than 1%. And the reason this is feared is because it can result in pelvic sepsis, and this can be potentially life-threatening. And then fecal incontinence is another one. Patients can experience fecal incontinence, and this is usually transient. Um, we think the hemorrhoidal piles contribute about 10 to 15% of the resting anal pressure in patients. So I am cautious about recommending hemorrhoidectomy to patients who have had, specifically women who have had traumatic birth and have had injury to the sphincter muscle. If they already have a baseline degree of incontinence, then I typically do not recommend excisional hemorrhoidectomy because it is more likely that it's going to worsen their incontinence. In other patients, if they do experience incontinence, this is usually transient and attributed to pain. In the operating room, I always visualize the sphincter muscle, so I know with certainty that I'm not injuring their muscle. The other group of patients that are also high risk are those that need to have a redo excisional hemorrhoidectomy because there's significant scarring at that point, and then the dissection does become a little trickier. Now, the sacral hemorrhoidopexy has really fallen out of favor. It really is not a true hemorrhoidectomy because we're not excising the hemorrhoid tissue. Essentially, what we're doing is using an end-to-end circular stapler, very similar to what we would use when we would do end-to-end anastomosis, except that we are not doing a full thickness, or at least not trying to do a full thickness. And it is used to excise a circumferential ring of the internal hemorrhoids, which includes the mucosa and the submucosa above the level of the dentate line. So it does nothing for the external hemorrhoids other than disrupt the blood supply to it and resulting in less engorgement of the hemorrhoid tissue that is remaining. When we do this, it brings the tissue together, the stapled is fired, and it circumferentially excises that tissue, and and then at the same time simultaneously moves the distal tissue up into the anal canal. So it almost forms like a pexy. So it is not a full thickness excision of the hemorrhoid. So it is technically not considered a hemorrhoidectomy, but just a pexy. Now, some of the benefits is that it's less post-operative pain. And this is because it is all staying within the anal canal compared to an excisional hemorrhoidectomy, in which that excision is extending to outside the anal canal. Typically reserved for patients with second and third degree prolapse. As I mentioned, it does nothing for the external hemorrhoids or for the prolapse tissue. So it's not usually used for patients or indicated for patients with fourth degree or thrombosed hemorrhoids. And the long-term data, it's a little difficult to interpret, but it does seem to be effective. And it is a benefit compared to excisional hemorrhoidectomies. It's going to be the post-operative pain. It is considered safe, although there are some very unique complications to it, and that can include perforation, obstruction, if you are not careful and actually close the anal canal when you fire off that staple. There are some other unique complications like rectovaginal fistula and retroperitoneal sepsis that can occur with this procedure. And because these are pretty big post-operative complications, we've kind of removed away from recommending this. So it has kind of fallen out of favor, but it is still something that you will find in the literature as one of the surgical options for a hemorrhoidectomy. The next one, which I think is probably taken the place of the stapled hemorrhoidectomy because the risk of complications is a lot less, is the transanal hemorrhoidal dearterialization. So this can be thought of essentially as a more in-depth or a more aggressive ligation rubber band ligation. Um, the benefit of it is that it can be done for bigger hemorrhoids or for hemorrhoids that have failed band ligation, where the patient does not necessarily want the hemorrhoid excised or they don't want to put themselves through the postoperative pain, or in those patients that we consider high risk for fecal incontinence. This was first described in 1995, and what we do is we use a specialized Doppler that allows us to identify the hemorrhoid pedicle, where we essentially tie it off and ligate it with a suture rather than a band. And then using that suture, we can pull up the hemorrhoid tissue and pexy it closer to the anal, more proximal in the anal canal. So it does bring up that tissue a little bit that is prolapse. Again, it's not excising any anoderm, so it doesn't resolve completely that external component of the hemorrhoid. But it is a very good option for those patients in which, as I mentioned, either don't want to go through the pain of an excisional hemorrhoidectomy, are at higher risk of fecal incontinence, and in which the office-based procedures like banding has failed. As I mentioned, the ligation is obviously less painful, again, because it is all above the dentate line. It is safe compared to the staple hemorrhoidopexy. I would say it's even safer because the risk of complication is pretty minimal, and it is even safer than an excisional hemorrhoidectomy. It does have a higher recurrence rate, again, because we're not necessarily excising any tissue, but because it's pretty well tolerated, low complication rate, we can offer repeat procedures of this similar to the patient. So I would say that in order of preference, for most surgeons, the to-go is going to be an excisional hemorrhoidectomy in patients that we don't think will benefit of that or have a contraindication for a full excision of the hemorrhoid. Then the transanal hemorrhoidal dearterialization would be the next one. And this is just a table that shows kind of when we reserve the excisional hemorrhoidectomy. It is of most benefit, obviously, for those who are a grade 3, grade 4, grade 3 specifically if rubber band ligation fails, but those for grade 4, and really is the only procedure that's going to address the external hemorrhoids. Again, you can see there's a lot of overlap in the grade 2 and the grade 3 internal hemorrhoids. So there are a lot of options for patients that present with this degree of hemorrhoid before we need to refer them for surgery. The special clinical scenarios where surgery or some intervention is indicated are those who present with thrombosed external hemorrhoids or those that come with strangulated hemorrhoids. And these are hemorrhoids that have thrombose but are also prolapsing. And I'll show you a picture of each. So the thrombosed hemorrhoid pain is typically one hemorrhoid column that is thrombosed. The worst pain is usually within 3 to 4 days. This is a procedure that can be done in office or in the ER, where we do a thrombectomy, and for me, it really is driven by symptoms. I don't necessarily have a timeline. If on exam the patient is still having significant pain, and when I palpate the hemorrhoid, it is still very tense, I do think these patients will benefit of a thrombectomy. So I will still offer it to them, even if it's past the 72 hour that we're typically taught is ideal for a thrombectomy. Again, it's a procedure that can be done under local. These patients are usually in so much pain already that anything that you can do for them will relieve the pain. We excise this by creating usually a cruciate incision, and then I turn that into an elliptical, and then I evacuate all of the clot at that time. The wound is left open. You may have a little bit of bleeding, which you can cauterize with silver nitrate or just put pressure, and usually that is sufficient. Eventually, this will heal, and the patient may or may not need a hemorrhoid surgery in the future, or this may be an isolated event. So I usually have patients come back to see me in clinic in 2 weeks just to ensure that the wounds have healed. And then if necessary, if this is something that is happening or recurring, then we may recommend surgery to definitively manage their hemorrhoids. Now, this is the strangulator or the thrombosed hemorrhoid. This is very different from that isolated thrombosed hemorrhoid. As you can see, while this patient has some pain and discomfort, usually they can sit. You walk into the clinic and they're still sitting, but they're experiencing significant discomfort. This is the patient that you walk into the room and are pacing back and forth and has to be laying on their belly or on their side just because this is so painful. And you can see that this is obviously something that needs to be addressed. This is when both the internal hemorrhoids are incarcerated and they're irreducible. There's typically a large amount of edema. These need to be addressed because they will progress to ulceration, necrosis, and eventually gangrene. And here, doing a thrombectomy in the office is inadequate. There's just no way that you're going to be able to decrease this amount of edema or do enough thrombectomies to provide any significant relief. And these are the one group of patients that require an urgent excisional hemorrhoidectomy. So these are the patients that I would admit from clinic and post that day for a excision. Now, they are at higher risk of those post-operative complications that we discussed, specifically the anal canal, the anal stenosis, because it's so edematous and there's so much inflammation that they may aggressively scar. But as I mentioned, it's usually something we can manage, and the amount of relief that they get is significant. Now, anal fissures, this is another group of patients that often get sent to us, especially if they have refractory anal fissures, despite treating with either topical nitroglycerin, nifedipine, or diltiazem, which usually I prefer the 2% diltiazem, but I don't know that there is really literature supporting one or the other. That's just what was trained to use and usually what I feel comfortable prescribing. Patients who have not had resolution in 8 weeks of treatment with the topical cream need to be re-examined. For one, we need to make sure that what we're treating is truly an anal fissure and not a malignancy, for example. For these patients, we have two options. We have a Botox injections or sphincterotomy. Now, the next step usually now is going to be a Botox injection. This is the next step in the management when the topical medicines have not completely either resolved the symptoms or has resulted in a recurrence. And the Botox injections relax the sphincter muscle. The effect of it starts within days and can really last up to 3 to 4 months. The healing rates are really high, up to 73%, extremely low complication rate. Patients may experience a little bit of incontinence, but it's usually not a frank incontinence. They still have voluntary control of their bowel movements. And the benefit of the Botox injections is that they can be done in the office for patients that can tolerate the injections. If not, we can do it in the operating room under sedation. And then we can do repeat Botox injections for those who have partial healing. And there's really no limit as to how many Botox injections we can do. Now, patients who have hypertonic sphincter muscles and anal sphincter muscles and have these recurrent or refractory anal fissures that don't heal even with repeat Botox injection, then those are the ones we would consider for sphincterotomy. And what this is a division of the internal sphincter muscles. And the healing rates can be up to 90%, so it is very effective. However, the rate of fecal incontinence is reported in anywhere in the literature up to 30 to 40%. So it is actually now very, very rare that we will resort to a sphincterotomy for a chronic anal fissure. And the reason the fecal incontinence rate is so variable is that when we are excising the muscle or cutting the muscle, it is really just very subjective, and there's no objective measure of how much muscle you're cutting. So that is why there's such a variability in the incontinence rate. So in general, we don't resort to this unless we have to, and we are sure that one, the anal fissure is a true anal fissure, that the patient has hypertonic sphincter muscle and have failed several rounds of Botox injections. And essentially, the sphincterotomy is we find the groove in the intersphincteric space. We put in, make a small incision, open up that space, and then insert our blade. And really, against our fingers, just start shaving off and cutting off some of that muscle until we feel a release in the tonicity. So again, not objective at all. All right, I think I'll stop here and answer any questions.
Well, thank you so much for that very comprehensive lecture. I have a question for you. When you inject your Botox, do you specifically inject into the internal sphincter or external, or does it matter? Can you hear me?
Yes, I muted myself. Yes, so we inject in the internal sphincter muscle. So usually we use 100 units of Botox. And what you're going to do is you're going to reconstitute it in 1 cc of sterile normal saline. So when you get the vial for the Botox, the powder is at the bottom. It almost looks like the vial is empty, and you question whether there's even any medicine there. But you inject 1 cc into the vial, you reconstitute it, and then you draw it up in a TB syringe with the smallest needle that you can find. And I usually have the patients on the lithotomy, table prone jackknife, and with my assistant retracting, I palpate the internal sphincter muscle, and that is exactly where I do half a cc of an injection, and then I do another half a cc on the opposite side. I don't inject specifically in the muscle where that is exposed for the anal fissure because it's really painful. But these little 2 injections, the patients usually tolerate very well. And I use a little bit of betadine, to wipe, to clean that area before I do the injection. Now, if I'm in the operating room, I usually reconstitute it in 8 cc's of saline. And then in the OR, then I do have the luxury to inject it in 4 different quadrants and even 2 cc's right into the anal fissure itself. But, I really haven't noticed a difference in how patients heal, whether we do it in the office or in the operating room. It really is more for patients who are like, there's no way I'm gonna let you come at my butt with a needle. Then in those patients, we do it under anesthesia. But that's what I do. 100 units of Botox and 1 cc of sterile normal saline using the TB needle, and you just palpate the internal sphincter muscle and you inject it.
Okay. So 2 questions from listeners. One is, how do I get training for Botox injections?
The Botox injections, we learned to do this in fellowship. I don't think there's a specific course. Um, I think this might be an opportunity, Dr. Qureshi, because I don't know, do you cover that in your hands-on when you're doing your presentation?
No, we're at the present time here at Baylor, we don't have any hands-on. So uh, all our hands-on are with our fellows.
Yeah.
So
Um,
I guess
you
the
know,
area would be they could talk to their own surgeons where they work if they have a hospital connection, and then see if they can get trained there or not. I'm not sure how you would get to train. Do the surgical societies have any opportunity for hands-on training?
yes. So the Society for Colorectal Surgeons, with the annual meeting, we do have workshops. And we do try to train a lot of our APPs on how to do Botox injections and procedures in office. So there is always an opportunity for that. But yeah, you're right. If there is a colorectal surgeon at your institution that is doing Botox injections in the office, and that is also an opportunity to learn. It's not really difficult. The risk of it is very low, right?
Mm.
So you probably just need to see one
Yeah.
to be comfortable enough to do it yourself, because the risk is so small that it's really hard to do it wrong. It may not be effective, but that's not to say that it was your injection. It just maybe the Botox wasn't effective for that patient.
Okay.
So
And there's one last question for you. How do you handle fecal incontinence after a sphincterotomy?
So these are difficult because there's obviously trauma that has been caused, really iatrogenic. So for these patients, usually there is a amount of scarring that is still going to take place as they heal from their sphincterotomy.
Mhm.
So after several weeks, um, if they continue to have fecal incontinence, then this is somebody that then we would refer to pelvic floor for pelvic floor exercises. As I mentioned, it's always a fine line, right? You want to be able to decrease the sphincter tone enough so that they heal their anal fissure. Without them having really any long-term sequela of the incontinence. So after they've healed the anal fissure, then if they're still experiencing fecal incontinence, then this would be somebody that we'd refer to our pelvic floor therapist.
Great. Dr. Rojas Khalil, thank you so much for all that information that you packed into 20 minutes. Excellent as always.
Yes, of course. Maybe the next time I can find a visual on how to do the Botox injections. I think that for a lot of people, they probably feel comfortable just watching one.
Mhm. Yeah, I think that'd be great to have a short video. So
Yeah, we can certainly work on that for the next time.
great. All right. Well, thank you so much.
Thank you. I appreciate it. Thank you
Thank,
for the invitation.
thank you. You're most welcome. Thanks for all your time, effort, and very useful information.
I will be giving this talk on dyssynergic defecation. Thank you for bearing with me through those technical difficulties. My objectives will be to define what is dyssynergic defecation, review the epidemiology and clinical characteristics of dyssynergic defecation, describe the workup and diagnosis of dyssynergic defecation, and then finally outline the treatment options for dyssynergic defecation. So we define dyssynergic defecation as any disturbance in the neuromuscular coordination between the abdominal, rectoanal, and pelvic floor muscles that lead to inadequate rectal propulsive forces and or an increased resistance to defecation. So put a little bit more succinctly, as the name states, dys is abnormal, synergia, coordination. So abnormal coordination of defecation. I put this little word bubble here because I feel like it kind of nicely illustrates the fact that Since this condition was first described in the 1980s, it's gone by a lot of different names: anismus, paradoxical puborectalis contraction, pelvic floor dysfunction, pelvic floor dysnergia, which can be really confusing. More recently, around 2006, the Rome Foundation kind of put forth, advocated for the term dyssynergic defecation to really standardize, this condition and just what we're talking about, so that we, are all on the same page there. So now just to review pelvic floor anatomy a bit, because if you go back to this, when we say pelvic floor dysfunction, that would include dyssynergic defecation, but also abnormalities in micturition or sexual dysfunction, because the rectum is not the only organ there in the pelvic floor. So what is important in terms of pelvic floor anatomy? So what we have here are the two most important muscles that make up your pelvic floor are the levator ani muscles and the coccygeus muscle. And these form this bowl-shaped diaphragm through which the rectum passes through the perineum to form with the anus. So the levator ani muscles are composed of the iliococcygeus muscle, the pubococcygeus muscle, and the puborectalis muscle. The puborectalis muscle forms this U-shaped sling around the rectum, which is important in the forming the recto-anal angle and maintaining continence. The internal and external sphincters are seen over here. Your internal anal sphincter is comprised of smooth muscle and contributes about 70% to resting anal tone. And then you have the external anal sphincter, which blends superiorly with your puborectalis muscle. And so these muscles are innervated primarily through the pudendal nerve, as well as the S2 through S4 sacral nerves. And coordination of these muscles is what leads to effective defecation. So what is the epidemiology of dyssynergic defecation? So it's actually very common and can be detected in up to 27 to 59% of patients who have chronic constipation, so a significant proportion of our patients. It can also overlap with slow transit constipation, as well as IBS-C or exist in isolation. It's more common in women than men, with the greatest incidence having somewhat of a bimodal distribution: younger patients between 20 to 29, and then older patients between 80 and 89. Whereas in men, the incidence increases with age up until 80 to 89. It's much more common in patients with Crohn's disease, threefold, but it's also associated with other conditions and risk factors, including IBS, anxiety and depression, as well as surgery, hospitalization, eating disorders, trauma, and physical or sexual abuse. Onset occurs commonly during childhood and around a third of patients, or it could occur after some sort of inciting event like pregnancy, trauma, or a back injury. But in many patients, we are not able to identify any specific cause. In terms of etiology and pathogenesis, we don't really know what causes dyssynergic defecation, but we do think there is some maladaptive learning that occurs potentially by avoiding anorectal pain or trauma, or neglecting to call to defecate. I actually had a patient recently tell me that when she was a child, she went to boarding school, the toilets were not hygienic, and she had learned to hold her bowel movement for a week until it was cleaned. So it was a good example to me of this like maladaptive learning. In terms of pathophysiology, that's a bit more straightforward and basically implied by the name. So we have this inability to coordinate the abdominal, rectoanal, and pelvic floor muscles to facilitate defecation, and can be due to any one of these below: inadequate propulsive forces, paradoxical anal contraction, and inadequate anal relaxation. And 50 to 60% of these patients also have impaired rectal sensation. So what are the clinical characteristics of dyssynergic defecation? Really, they're indistinguishable from any other cause of constipation. Patients will have infrequent defecation, hard stools, excessive straining, may need to use manual maneuvers to facilitate defecation, and have a sense of incomplete evacuation as well as abdominal bloating. So I think it's interesting to point out that highest percentage for excessive straining and sense of incomplete evacuation, but also really high for abdominal bloating, which is a very common symptom that brings patients in to see us as gastroenterologists. So what should you think of as a potential differential in a patient who you suspect has dyssynergic defecation? So other disorders of gut-brain interaction or functional conditions like IBS, also slow transit constipation, as well as some of the structural pelvic flora problems like rectal prolapse, rectocele, and descending perineum syndrome. These things can also coexist with dyssynergic defecation. So just things to keep in mind as you're going through your evaluation. And how do we make the diagnosis of dyssynergic defecation? So for the next several slides, I'll go through the different tools we use, starting with a digital rectal exam. Then I'll talk some about anorectal manometry, balloon expulsion testing, as well as defecography, and then summarize the criteria that we can use to make this diagnosis. So starting with the digital rectal exam, so there is evidence that supports a properly done digital rectal exam can have a high sensitivity of around 75% and high specificity of 87% to diagnose dyssynergic defecation in patients who have chronic constipation. But despite this, it remains a very underutilized tool, even by gastroenterologists. And a survey of 652 patients, respondents that included PCPs as well as GI fellows and faculty, only 56% had a low comfort level, either not at all, a little, or somewhat comfortable with performing a digital rectal exam. And not surprisingly, the level of experience directly correlated to a higher frequency of performing a digital rectal exam, lower patient refusal rate, degree of comfort, and diagnostic confidence. So that's why I'm going over the next few slides to spend a bit more time talking about how to do a DRE in the context of a patient who you suspect may have dyssynergic defecation, even though I think it's been covered a bit already. All right, so the methodology. So digital rectal exam in a patient who you suspect has dyssynergic defecation. It is not your inpatient check for melena exam. There are several steps, and I'll go through each of these. So first, you're just going to inspect. So does the patient have any tags, hemorrhoids, fissure? These things can often be comorbid. You're going to next look at their perianal sensation, and for the anocutaneous reflex, you'll use a cotton bud at the end of a stick to stroke the skin in each quadrant in a centripetal fashion towards the anus, and then look for a normal or impaired response. Digital palpation to look for any mass, tenderness, stricture, and then also you'll take note of their resting tone at that point. And then you'll do a series of maneuvers. You'll ask the patient to do a few squeezes and to get a sense of their ability to squeeze, bearing down and checking for coordination of the abdominal muscles. You're looking for relaxation of the external anal sphincter and puborectalis muscle, and for perineal descent. And so you can actually make a clinical diagnosis of dyssynergic defecation if you're lacking any of these two components during their bear down. So these are just some more images to kind of drive the point home. So starting with first position, you'll insert your examining finger shallowly to check the internal and external anal sphincters, taking note of their tone at rest. Then you'll ask the patient to squeeze so that you can take note of their strength. And then in a second position, you'll insert the examining finger a bit deeper, where you'll take note of the puborectalis muscle, and both at rest and then again with squeeze, where you should actually feel the tension from the puborectalis against your finger. And then with expulsion, you're going to take note of a few different things here. You should feel the puborectalis relax against your finger. That leads to widening of the rectoanal angle. You'll also feel relaxation of the anal canal and the perineum descend. Okay, so that is our DRE for a patient with dysnergic defecation. Now moving on to anorectal manometry. So this is a very useful test to look at anorectal motor and sensory assessment and obtain some more objective markers. So the top image here just has some examples of the different catheters that are used for this. And then the image here is what's generated. On the right-hand side, this is the old tracing before kind of advances in technology. We had a limited number of sensors that basically would provide one tracing for the rectum and a tracing for the anal sphincter that were interpreted separately. Now, similar to what we have for esophageal manometry, we have color mapping topography. So this provides on the x-axis, over time, and then on the y-axis, you can see basically from distally in the anus to more proximally in the rectum, and the colors correspond to differences in pressure. So blue would be low pressure and red is high pressure. And so what you can see here is, initially the patient is at rest. You have an increased normal tone here, the anal sphincter, and then the patient does a bear down. So before that, the rectum is relaxed. With the bear down, you see some pressure generated here at the rectum, and then in the old tracing, again, kind of the same thing. At the same time, you see relaxation here of the anal sphincter. And then after the maneuver, everything goes back to how it was before. So this is what anorectal manometry looks like. So when should you use anorectal manometry? So of course, the main focus of this talk is patients who have chronic constipation that's refractory to standard therapy. But it's also important in patients who have fecal incontinence, patients who have chronic anorectal pain, as well as if you suspect Hirschsprung's disease, megarectum, or megacolon, and in some preoperative cases, such as fistulotomy, lateral sphincterotomy, or rectopexy. So the International Anorectal Physiology Working Group came up with a protocol of how to perform anorectal manometry to somewhat standardize how it's performed at different centers. And so this is basically how it's done. On the left, just kind of going through in time, you can see the patient, first goes through a period of stabilization to get used to the catheter that's placed there. Then they do the maneuvers where they'll do some short squeezes, a long squeeze, some provocative maneuvers like coughing to check for reflexes, and then some pushes, followed by rectal sensory testing, and then something called the RARE, which I'll go over here in a second. So what this allows us to do is objectively look at contractility and tone of the internal anal sphincter and external anal sphincters, look at the reflex contraction of the external anal sphincter in response to cough or Valsalva. So, when you have an abrupt increase in your abdominal pressure, you should have a reflexive contraction of your anal sphincters. It also looks at dynamic change of rectal and anal pressures during simulated evacuation. So we'll go over that in a bit more detail on the next slides. This is what we're kind of focusing on when we're thinking about dyssynergic defecation. Also looks at rectal sensitivity and compliance. So the catheter has a balloon at the tip, and that balloon is inflated at varying amounts until the patient feels it, and then that is noted. Then they make a note of when the patient feels an urge to defecate, and then the maximum tolerated volume. And so these are some of the variables that are looked at. And then finally, the reflex relaxation of the internal anal sphincter in response to rectal distension. So that is what we refer to as rare. And this is what is normally should occur, when there is something there in the rectum, a signal should be sent to relax the internal anal sphincter. And that is what tells the patient they need to eliminate what they can use external anal sphincter to wait until an appropriate time. So these are just some images of what your anorectal manometry would look like. So just first at rest, we've got a normal example here in panel A. You see that there is good tone and the rectum is relaxed. Panel B, this is anal hypotension, really low pressure of the anal sphincter, rectum is relaxed. In panel C, we see a normal example of squeeze. So you have your baseline anal pressure, an increase with the squeeze that goes back to baseline, and then another increase with the squeeze with the next maneuver back to baseline. And then panel D is an example of abnormal where you really don't see any change in pressure with the squeeze attempt. And here's an example of what we were referring to earlier, the abdominal pelvic reflex. So it can be done a couple of ways. One is with a cough, or you can fill up the balloon to simulate the increase in abdominal pressure. But here is a normal response where you see that with that, the anal pressure increases to maintain continence. And then here is another example of the rectoanal inhibitory reflex, or RARE, where at baseline you have your sphincter tone here. As the balloon fills, you have increase in pressure of the rectum, this simulates stool. And then you have this reflexive relaxation here. So you see that it's relaxing and this is normal. If this is absent, you may have dysganglionosis, or it could be, in the case of patients who's had surgery, like a low anterior resection. Okay, and now the types of dysynergic defecation. So there are 4 different manometric patterns that we see for dysynergic defecation. And probably, if you're not reading these, you don't really need to remember the different subtypes. But just to kind of go through what they are, in case you see them referenced on a report or something like that. I like to remember them by first thinking about what's happening in the anal sphincter. So for types 1 and 2, you can see that with a bear down attempt, the anal pressure is actually increasing. So in both of them, from baseline, anal pressure is increasing. In type 1, you actually do have normal rectal pressure. It's just not enough to overcome this difference. In type 2, you have an increase in anal pressure, just like with type 1, but your rectal pressure is also inadequate. In types 3 and 4, you don't have an increase in anal pressure, but you do not have an adequate relaxation. So still not able to overcome the differential from rectum to anus. And similar to types 1 and 2, type 3, you have adequate bear down or adequate rectal push in type 3, but not in type 4. Okay, so that's our anorectal manometry, and complementary to our anorectal manometry, and in our center done at the same time, is the balloon expulsion test. And what this is an assessment of the time to evacuate a balloon filled with warm water in the seated position. And usually this is done with 50 milliliters, but an alternative would be to use the volume at which the patient had a desire to defecate. And then the upper limit of normal is typically considered to be 60 seconds with commercially available balloons. But if you were using a Foley catheter, that could be higher. And this has been shown to have a high specificity of 80 to 90% for dysynergic defecation, though the sensitivity is lower, around 50%. So these are just some examples of different balloons that have been looked at for this purpose. So on the far left, a party balloon, so just one that you could get at your usual store, a Foley catheter that you have at the hospital, and then a commercially available balloon. So this was a study that looked at 40 women, with 40 women who had, no dyssynergic defecation. Essentially, what it found was that really commercially available balloons are probably preferred. You don't have the risk of latex exposure, and they have better reproducibility. So if possible, it's best to use a commercially available balloon. Okay, so now I'm going to move on to defecography, which is another complementary tool that we use to diagnose patients with dyssynergic defecation or other pelvic floor conditions. And it comes in two main modalities. The first is barium defecography, and the second is MR defecography, which I'll go over on the next slide. Barium defecography is done by using 150 milliliters of barium paste inserted into the patient's rectum. They sit on a specialized commode, and then images are taken while they bear down. This does involve some radiation to the pelvic region, which I guess that's a con. But more importantly, the equipment is antiquated and few radiologists are trained or knowledgeable about the technique. So really it has become essentially obsolete, and it's for the most part not available to us. So that brings me to magnetic resonance defecography. And what this does is evaluate pelvic floor anatomy as well as dynamic motion and rectal evacuation all simultaneously. It gives excellent resolution of our anal sphincters, the levator ani muscles, and soft tissue surrounding the rectum. And of course, doesn't involve any radiation exposure. But there are still some limitations. So there's a high cost. It's not widely available. And there may be a possible low sensitivity to detect rectal intussusception. And it's done in a semi-recumbent position, which is, of course, not physiologic. So kind of bringing together the anorectal manometry, balloon expulsion testing, and MR defecography, there is a classification system called the London classification. And this was developed also by the International Anorectal Physiology Working Group to take the objective, functional measurements that we get through anorectal manometry, and particularly with complementary balloon expulsion testing or defecography, to come up with kind of manometric diagnosis based on the findings, major findings, minor findings, or inconclusive findings. And this is kind of similar to, the Chicago classification for esophageal motility disorders. On the far left, the disorders are listed: disorders of rare or rectal-anal inhibitory reflex, disorders of anal tone and contractility, disorders of anorectal coordination, which is really our focus today, and then disorders of rectal sensation. So focusing on disorders of the anorectal coordination, moving over to minor findings. So this is where we, look at both our anorectal manometry and balloon expulsion, or if not balloon expulsion, defecography, and combine those to come up with a diagnosis. So you may have abnormal expulsion with dyssynergia. So either an abnormal balloon expulsion test or defecography with dyssynergia, which is either the anal contraction with bear down or lack of anal relaxation, abnormal expulsion with poor propulsion. So again, an abnormal balloon expulsion or defecography, and the patient is just not able to generate enough push, or a combination of the two. So abnormal balloon expulsion or defecography with both poor propulsion and dyssynergia. So this is a more simplified way. Instead of thinking of the different types 1, types 2, type 3 dyssynergia, it simplifies it. And then just here in conclusive, if you have disconcordance, so if you have a normal balloon expulsion but an abnormal pattern, you're not able to really make that manometric or that diagnosis based on this London classification. Okay, so bringing all that together, clinical characteristics plus our testing, there is a Rome 4 diagnostic criteria for dyssynergic defecation that patients must satisfy a diagnosis for functional constipation and or constipation predominant IBS, and they must have a dyssynergic pattern on repeated attempts to defecate, which is the abnormal anorectal manometry. And then they have to have either an ability to expel that artificial stool or the balloon expulsion testing, or on defecography, they're not able to evacuate at least 50% of the barium. Okay, so now that we've made that diagnosis, moving on to management. And I think this has been covered a bit already. We start with conservative measures, adequate fiber and fluid intake, ensuring the patient is regularly exercising, but some behavioral things that can be done as well, like proper positioning, using something like a squatty potty or a stool, avoiding postponing of defecation, things like timed toileting, trying to have a bowel movement at least twice a day, usually after waking or after a meal, about 30 minutes, and pushing at about 50 to 70% of their maximum effort, and not straying for more than 5 minutes. Drugs haven't been, really systematically studied in patients who have dyssynergic defecation, but are certainly frequently we use as adjunctive. May simply be over-the-counter laxatives, or we may use intestinal securitagogues or serotonergic agents as well. But really, biofeedback is the mainstay of treatment. And what this is an instrument-based operant condition technique with the goals of correcting dyssynergia or incoordination of the abdominal and pelvic floor muscles during evacuation, and to improve perception of rectal filling in patients who have impaired rectal sensation. In terms of the evidence for biofeedback, there have been several randomized controlled studies performed, generally with small sample size, but in each, biofeedback was found to be superior to the comparator. And overall treatment efficacy is about 70 to 80%, so it can be very effective. In terms of the biofeedback protocol, our pelvic floor therapist can probably give you even better information about this, but in terms of what's in the literature, you'll see 3 phases of biofeedback therapy for patients who have dyssynergic defecation with constipation, starting with just a patient evaluation and education, reviewing a stool diary, assessing their symptoms, a review of their anorectal function testing, such as anorectal manometry, and reviewing with the patient what is normal physiology of defecation versus the pathophysiology of dyssynergic defecation, using techniques like diaphragmatic breathing and the behavioral modifications that I ran over previously. The active phase of biofeedback may consist of 6 30 to 60-minute sessions, 1 to 2 weeks apart, for anywhere from 6 to 12 weeks, where the patient is getting visual and audio feedback from a screen, potentially using a manometry probe, could be using electromyography probe, simulated balloon, getting verbal feedback from the therapist, and then practicing at home. And then that would be followed by a maintenance and reinforcement phase where the patient has periodic follow-up to reevaluate and adjust as needed. There is some evidence that home biofeedback training, use of a home biofeedback training device may be as effective, but we don't yet have a commercially available device at this point in time. And this is just an example of a manometric tracing in a patient before and after biofeedback therapy. So before biofeedback, you can see that the anus, we have a paradoxical contraction. And then after, you see good relaxation of the anus there. Okay, and I think this is my last slide. So just to kind of bring everything together with a nice algorithm from the ACG guidelines on benign anorectal diseases a few years back. So in patients who have symptoms suggestive of dyssynergic defecation, you're going to first optimize, conservative management strategies, ensure they're adequately hydrated, getting fiber, considering laxatives, If they have a good response, great, continue that. If not, then that's when you should consider anorectal manometry and rectal sensory testing with balloon expulsion. If they have dyssynergia, you should refer them for anorectal biofeedback. If that fails, you might consider defecography to ensure that you're not missing a structural abnormality. But if you find dyssynergia again, then consider repeat biofeedback. And thank you for giving the opportunity to present, and that's all I've got.
Thank you, Jessica Bernica. That was excellent talk. It is my pleasure to welcome Catherine Osterhaus, who is who's a physiotherapist specializing in pelvic floor dysfunction. She works out of the Methodist Hospital in Houston. Welcome, Catherine, and tell us about physical therapy for pelvic floor dysfunction.
Hi, thank you for having me. My name is Catherine. I am a pelvic floor physical therapist. I work at Houston Methodist, and I'm in the medical center in Smith Tower on the 6th floor. I wanted to be sure to give Albina Heidebrecht credit too. She assisted in putting together this presentation. There are 5 of us in Smith Tower in the medical center, but also many Houston Methodist locations around the greater Houston area that have pelvic floor physical therapists if you ever need our help. So I'm going to be talking about what we can do to treat patients for dyssynergic defecation. So we'll review the diagnosis and components of dyssynergic defecation briefly because Dr. Bernica did a really good job of that. And then we'll spend a little bit more time discussing the ideal setup for proper defecation mechanics, understanding common musculoskeletal causes of dyssynergia, and then we'll talk about how pelvic floor PT can help in this treatment, including various types of biofeedback and lifestyle modifications. So a brief overview, for time's sake, I won't read out the definition, but the main thing I wanted to point out here was that it is helpful for us as pelvic floor PTs if we have some of the diagnostic testing done beforehand, such as anorectal manometry, defecography, and maybe a colonic transit study, because it helps us get a better big picture of the patient and what all is going on in their symptoms, and are there other causes and contributions to their constipation. So Dr. Bernica also pointed out that it is important to educate patients about normal or typical anatomy and physiology during defecation. So sometimes I'll pull up a picture like this, maybe a simpler version, but I do discuss with the patients, at rest, your puborectalis muscle is responsible for kind of kinking the rectum, and it creates that anorectal angle. And then also at rest, the anus is closed. But when you're pooping, ideally that puborectalis muscle relaxes and the anus opens, which allows stool to come out of the rectum. So this is what should be happening when we're pooping. And it's interesting to me how often patients have no idea that things should be relaxing when they're pooping. That's surprising to a lot of people. We also talk about ideal defecation mechanics and posturing during toileting with patients. And I say ideal because this is what works for a lot of people, but it doesn't work for everyone, which is why we like to see them in their clinics so we can kind of trial and error different positions and verbiage with patients to help improve dyssynergia. But commonly what works well is leaning forward so your elbows can rest on your knees, allowing your body to relax. At least having their feet supported on the floor, but even better than that is having your knees elevated there above your hips, and that allows or assists the puborectalis muscle in relaxing. As you're pooping, we want you to think about pushing out or really expanding the belly as if you've swallowed a beach ball, and they should feel a widening of their waist. This is an eccentric contraction of the abdominal muscles, the opposite of what would happen if you were engaging your core, like to do a sit-up. And then lastly, again, we want opening and relaxation of the pelvic floor rather than tightening around the anus. So there are 4 types of dysenergic defecation, depending on whether or not the patient can generate adequate propulsion force through the abdominals, and then whether or not the external anal sphincter and puborectalis are dysenergic. So to reiterate the normal pattern up top, ideally there is an increase in intra-abdominal pressure, which is what we're seeing next to rectum there. And then at the external anal sphincter, we should have relaxation. These pictures on the right are very similar to what we see when we do surface electromyography with patients in clinic, but there will be another picture of that in a few minutes. So what causes dysenergia? And this is kind of thinking about it from our lens as we're trying to figure out why the patient ended up in our clinic. Sometimes there is a spasm of the external anal sphincter, although this is unlikely the only cause of their dysenergia. Often there's a lack of recto-anal coordination, so they're unable to generate that intra-abdominal pressure while relaxing the pelvic floor muscles. We see
We lost you there. Catherine?
Your call has been forwarded to voice.
No sound. Okay, we've lost signal from Catherine. Let's see if we can get that fixed. Rob, are you there?
Yes, sir. We'll just have to wait for her to rejoin.
Okay, all right. So we'll give that a minute for her to reconnect. And in the meantime, let me just look at some of the questions going on here. Let me see. Hello, Catherine. Okay, well, why don't you try to connect if you can, and if you do, we'll carry on from where we stopped. Okay. Okay, just log back on when you do. Okay. Great, thanks. Thanks. Okay, so I think her internet seems to have failed. So what I'm going to do is address some of these questions, and if she is not on by then, I will carry on with my last part. So,
Okay, she's back on.
Oh, okay, great.
Jessica, you need to unmute your mic.
There you are.
Hi, sorry about that.
No problem. Welcome back.
Thanks. Okay, I think this is working. No. Okay, so then we have these patients who are habitual butt grippers or walk around with their glutes clenched constantly, commonly in response to stress and sympathetic overactivity, which results in puborectalis hypertrophy. And then lastly, we can find trigger points at the puborectalis and external anal sphincter. So treatment protocols for dysenergic defecation. Biofeedback therapy is the mainstay treatment for dysenergic defecation, and the goals are to correct the dysenergia or incoordination of the abdominal and pelvic floor muscles, and then secondly, to improve perception of rectal filling in patients with impaired rectal sensation. Commonly, when people hear of the word biofeedback, they think of the surface EMG, but there are many different types of biofeedback which we can use in physical therapy. So we do use SEMG, but we can also use rectal balloon catheter defecation simulation, manometry, and then also a digital rectal exam. Those are all common types of biofeedback. Prior to biofeedback, patients should be educated in normal physiology of defecation. It is really helpful for patients to understand what should happen before we try and have that happen in their own body. We also talk about appropriate posture, as we all recently discussed, and then we use breathing a lot to help with these patients, and we'll talk about that more in a minute or so. And lastly, a digital rectal exam should be performed first before any other kind of biofeedback. It also, it gives us a good baseline understanding of what's happening. It can sometimes be more accurate depending on, what you're going for. It can be more accurate than surface EMG, but also allows us to begin any manual therapy if necessary. And then biofeedback is designed to improve that abdominal push effort without excessive straining, also while getting relaxation of the anal sphincter and puborectalis. So again, 3 phases of biofeedback, starting with symptoms with subjective examination, explaining what should happen when we're pooping and why dyssynergia happens, going over diaphragmatic breathing, educating on timed toilet training if necessary. So this would be encouraging patients about 30 minutes after each large meal to go sit on the toilet for 5 minutes. And I liked what Dr. Qureshi said earlier this morning, no more than 5 minutes. We really emphasize that with our patients as well. And then in the active phase of treatment, different feedback techniques, whether that's, patient handouts for visual cues, having them look at the computer screen during SEMG, or listening to our verbal cues as we're working through how to coach them to improve the dyssynergia. According to research, sessions should be between 30 to 60 minutes long, about 1 to 2 weeks apart for 4 to 6 sessions, and then supporting that with home devices or home biofeedback units as necessary. We have the luxury at our clinic, and this is pretty typical for most pelvic floor PT, we get to see our patients anywhere from about 45 to 60 minutes each session, and we're always one-on-one. So it's really nice to have that one-on-one time with our patients. And then third, hopefully there's some sort of reinforcement at those following weeks to make sure that patients can keep up with what they've learned in our clinic. So these screens on the right are very similar to what we would look at if we're doing SEMG in the clinic with our patients. The screen up top is measuring intra-abdominal pressure, and then the screen below is measuring pressure at the external anal sphincter. Commonly, if we're doing this with patients, I'll only have the bottom pictures pulled up or the bottom screen pulled up, just because looking at the two can get confusing for patients. And this is where I wanted to kind of talk through some of the cues that we use often in clinic with our patients as we're coaching them to improve the dyssynergia. So I do often start with breathing. And I explain to my patients the reason why we're starting with breathing is because we can use breathing, specifically diaphragmatic breathing, to help make sure that our pelvic floor can move through its full range of motion. So typically I'll start with my patient in supine, be connected to EMG, but often at first it's with, no biofeedback, no digital rectal exam, just them lying down on the table. And I'll talk them through how to take some nice, slow, soft breaths. And what I'm for when patients start breathing like this is I'm looking for them to get a good amount of lower abdominal expansion with some posterior lateral rib cage expansion as well. So a lot of people are used to just breathing into their upper chest, but in order to start getting this pelvic floor descent as we inhale, we really want to encourage that air to move all the way down into the lower belly. So giving them tactile and verbal cues as needed to get that lower abdominal expansion. So I'll say, inhale, I want you to send the air all the way down to the lower belly. And then exhale, think about just sighing and keeping your belly and your pelvic floor soft and kind of open. So inhale, the air is going all the way down to the pelvic floor. Exhale, keep things soft. And then we work through that. And at some point I ask them to start noticing what's happening in their pelvic floor when they're breathing. I'll ask them, do you feel anything moving as you're breathing? Sometimes they say, oh yeah, I feel inhale, things are relaxing and opening. And that's ideal. That's what we want. But a lot of people, their response is, no, I have no idea what's happening. So I I still say, you know, just keep checking in with your pelvic floor. We want you to be able to feel an opening and relaxation at the anus when you inhale. But for a lot of people, we don't feel that at first, and that's fine. And so then we do the same breathing as I'm doing my digital rectal exam, so I can confirm or deny whether they're actually getting pelvic floor descent and opening at the external anal sphincter. And again, we can cue them to change the way they're breathing to get more opening if needed. And then we can use different cues and different breath sounds on the exhale to further encourage that descent and opening of the puborectalis and external anal sphincter. I always ask patients to show me, first I'll say, push like you're having a bowel movement. And it's really interesting to see what patients do there. But then I'll also make sure that I have them show me what they do when they're pooping, because for a lot of people that's different. They have like what they think they should do, and then they have what they really do when they really have to get poop out. And so it gives you a good idea of what they actually do when they're on the toilet. When I'm internal, I still have them breathe, and then on the exhale, I can use cues like encourage that air to move down and out through the anus, or think about expanding your anus, opening it like a budding flower. I'll also say, you know, inhale, belly gets big, exhale, keep the belly hard as you encourage my finger to move out of the anus. I really try and avoid saying the word push, because for a lot of people, pushing doesn't work well, and that causes dyssynergia. Sometimes it does really help, though, for them to just think about pushing with 25% effort. So sometimes just cueing them to use a little bit less effort can be helpful as well. And then lastly, talking about, you know, as you exhale, I want you to pretend like you're exhaling through a straw. Doing that like pursed lip exhale can help generate the right amount of intra-abdominal pressure without it being excessive. We can also have them do like a low pitch hum, or say different breath sounds like grrr as you're exhaling can work as well. So it's a lot of trial and error and figuring out what works well and what doesn't work well, and then really running with what does work well. Sometimes, you know, this can happen very quickly within like 15 minutes in one session, but a lot of the times it takes many, many sessions to figure out what works well for the patient. So another type of biofeedback that we can use is the rectal balloon catheter. This is nice because now we're getting patients up into sitting, which is how we actually poop. No one usually poops on their side. So it's a little bit more functional, and we can also inflate the balloon to simulate stool moving through the rectum. We can also have them practice defecating with the balloon while attached to biofeedback, so we can kind of confirm what's happening with muscle tone as they're evacuating the balloon. So bedside commode training is after I've done my digital rectal exam. At some point, I want to see how they're pooping when they're sitting upright, because it is more functional. It feels right to the body and brain. Patients will be like, well, I don't know how to poop on my side. Why are you asking me to do it? But that's how we have to start, because I can't really do a rectal exam while patients are in sitting. So this is also nice because it allows gravity to help. We can do it at the same time as the SEMG or rectal balloon catheter. And then it helps patients determine and learn appropriate posture, breathing, and push mechanics. So we educate and talk about ideal posture, but in sitting with the surface EMG, we can try with a squatty potty, without a squatty potty, and patients can really actually see what works best for them. You know, for most people, leaning forwards works best, but for some people, actually doing a backwards lean works better. So we can trial different postures, and they can see what works best for them on the computer screen. It also helps. I had a patient yesterday who is very dyssynergic, and she is very hesitant to try anything else because she always tells me, she's like, I know this isn't going to work. It feels like it's not going to work. I feel like I need to push harder and push more. So I said, okay, well, show me what you do when you push. And she did what she usually does on the bedside commode. And I had her connected to SEMG, and it increased like crazy. And I was like, okay, I know that's what you feel like you need to do because that's what you've done for 35 years. But look, now you can see on the computer screen that things are tightening and closing instead of saying staying low and relaxed. So it helped kind of confirm what I was trying to get her to do. Other forms of biofeedback, we can have patients blow up a balloon to create that appropriate push effort, especially if patients are having a hard time feeling what's happening in the pelvic floor. Sometimes using a mirror to view the anus and opening and view the perineum descending can be helpful. And then having patients practice that push effort while sitting on a ball or a towel roll can be really helpful, because if they're practicing this like while lying down in bed before they go to bed, there's not any tactile feedback at the perineum to help them feel, are they contracting or are they opening and relaxing? So doing that in sitting, especially sitting on something, can be helpful. And then we also spend a lot of time talking about lifestyle modifications, and some of this has been talked about before, but talking with their physicians if needed about what medications are they taking and are those contributing to constipation. Adequate fiber intake, especially if we're increasing fiber, they have to be drinking enough water. Regular exercise is very helpful. If there's one thing that I ask patients to start doing if they haven't been doing any sort of exercise, walking, especially in the morning and after each meal. Avoid postponing defecation. So if you feel any pressure in the rectum, or for some people, they don't get pressure in the rectum, but it's or abdominal discomfort or cramping, go to the toilet and see if you need to poop, but don't sit for more than 5 minutes. We talked about the time toilet training part, and we talked about cueing patients to push with less effort. So whether that's 25 or 75% effort can be helpful. And then refraining from digital disimpaction of stools when able, just because it can be really irritating for that tissue. And at that point, they're not giving their muscles the chance to work. Different from like external perineal splinting, which is helpful and necessary for some patients. So that's all that I have. I want you to feel like you can email me with any questions, or if you have questions about patients or wonder if they're a good candidate for pelvic floor PT, I'd be happy to chat.
Thank you, Catherine. That was excellent. So I have a few questions. It says, is there a place to learn rectal manometry for someone who has not been formally trained in this? Catherine, what do you think?
I'm wondering if you're talking about like anorectal manometry testing that physicians do and then send the patient to us. We do more of the like rectal balloon catheter retraining, which is similar to the testing, but we're not actually obtaining values from that information. We're using it for like the dysenergic, to coach through dysenergic defecation.
Okay. But so someone's asking, what are your thoughts about the MedSpira M Compass office rectal manometry device? I haven't used it. We've always had a manometry section, motility department. So anybody know about this device? I think it's office-based.
I'm not familiar with it, but I was just going to say for like training on anorectal manometry, the American Neurogastroenterology and Motility Society, I believe, does have some training programs.
Okay, so so they can always go to their website and get more info on how to do that. And I have a question from one of our listeners. Does sexual history affect biofeedback therapy, and do you have to counsel them if they engage in anal receptive intercourse?
Sexual history affects what we do in pelvic floor PT, specifically the anal receptive intercourse part. I think it depends on what their symptoms are. It's possible that anal receptive intercourse could be irritating to the area and maybe contribute increase in tone or tension of those muscles, but it would kind of depend on how the patient is presenting to us. And, we meet the patient where they're at. So if that's a goal of theirs to continue performing anal receptive intercourse, it's not something that we would take away from them, but maybe talking about how they're going about it or frequency, duration, that sort of thing.
Okay. And I think it says, can you, maybe this is for you, Bernica. It says, can you comment on diagnosis and management of levator ani syndrome?
Sure. I think for that, your suspicion would be based on the symptoms. If they're having pain lasting like 30 minutes or more, and you on your digital rectal exam don't find an alternative etiology, and they usually have tenderness when you palpate the puborectalis. So it's more of a clinical diagnosis, but you may use anorectal manometry to see if they have, dysnergic defecation as well, contributing to those symptoms. And it may show rectal hypersensitivity on that rectal sensitivity testing.
Okay. Catherine, do you guys get these patients to deal with?
Yeah, with levator ani syndrome.
Mm-hmm.
Yes.
And physical therapy, your pelvic floor therapy works for them, or what do you do?
Yeah, it's definitely one of the diagnoses that we see a lot and really can help with. And I tell a lot of patients too, like I've never had a patient come to pelvic floor PT and not learn something from it, not take away something from it. So sometimes there has to be more intercollaboration with physicians and what else can they help you with that I can't help you with. I can't fix everyone, but I have a lot to offer, especially with diagnoses like the levator ani syndrome, because a lot of the time that is, we do find increased muscle tension or irritation to the nerves around the area, and then we're trying to figure out why did that happen in the first place.
Okay, all right. Now somebody's asking, would anal sex cause a patulous anus, and have you seen it leading to incontinence later?
I'm going to be honest, I don't have much experience with patients with that diagnosis, so I'm not really sure.
Okay, and I think do you see a lot of people with incontinence that you treat?
Yes, a lot.
Okay, and I suspect that they would end up with you if they came to us. And usually, with incontinence, we usually do an anorectal manometry, demonstrate that there is lack of sphincter pressure, and then we sometimes do an EUS to make sure that the sphincter mechanism is intact, and they don't, there isn't a tear where they need surgery
Yeah.
to fix. But otherwise, I guess if they were intact, they would come to you for therapy, right?
Right. And all of that, I kind of spoke to this earlier, but all of that like diagnostic testing beforehand is very helpful for us to kind of rule out any causes to the incontinence that pelvic floor PT would be less likely to help with. But a lot of the time, especially in the patients that do end up with us, it is muscle weakness and also combined with maybe non-optimal stool consistency. So I always tell patients it's really hard to control that like type 6, 7 stool.
Mm-hmm. Sure. Okay, I think that's most of the questions. In the interest of time, I will do the final roundup. Can you see my slide? You can see the end, which is almost there. All right, so starting your own hemorrhoid clinic, this will be brief because we've covered a lot of this before, and we're running a little behind, so bear with me. I'm always running behind. It's either patients or... Okay, so somebody had asked about the CPT code and work RVUs. So CPT code for banding is 46221. For each band you place, Medicare pays you about $270, and the work RVU is it's equivalent to an EGD 2.36. Okay, so So it is worthwhile. Not only do you look after your patients in a more comprehensive way, and you're not sending them off to surgeons and they may never return to you again, but it's well within your realm to be managing most anorectal symptoms. And that is why I think there's clearly a move now for gastroenterologists to do more anorectal disease management, which is good. So if you're thinking about starting a clinic, what do you need? And I just wanted to show you some few brief slides. Oh, why isn't this? Oh, all right. So what you need, requirements for an office setting include, of course, a nice, comfortable bed that you can raise, usually to your nose level so that you can see what you're doing. A good source of light, gloves, anoscopes, banding and infrared devices, nitroglycerin ointment. It's always good, one, because if you have a very tense patient and you want their sphincters to relax a little, you can use a nitroglycerin ointment before you go in with your anoscope, although that is rare for you to need that. But sometimes after banding, if they're really anxious and tightly, they need to relax and get comfortable, you can always put some nitroglycerin ointment and give them a few minutes to calm down and then do what you need to do. You obviously need KY jelly, and lidocaine gel helps. You need injectable lidocaine 1%, and you need that kit. The one I have just is my own made suture kit to include a scalpel, clamp, scissors, and gauze, and that'll take care of any thrombosed hemorrhoids that show up in your clinic. You need a well-lit, uncluttered room. This is our procedure room in the clinic, and I think it's used by various different subspecialties, but we have it reserved 1 day a week for our hemorrhoid clinic patients. And all our stuff is in there, in those cupboards in the back, including the IRC and all the banding devices. And there are several different types of slotted scopes. I would recommend a built-in light disposable scope. The built-in light gives you great illumination of the hemorrhoids and the anal canal without you having to have a light behind your head, and then you're trying to stay out of its beam and trying to get a look at the same time. This is a slotted scope, right? When you put this into a patient, the hemorrhoid bulges through this into the lumen of the scope. And to go to the next hemorrhoid, you have to take it out, put the trocar back in there, and turn around to that column, and then put it back in and look. Because if you rotate it and it's bulging through, it might cause trauma or discomfort. The advantage of a slotted scope, it's shorter on this side than on the other side. So that lets you rotate the scope easily. And so that is my preferred anoscope. And then there are so many banding devices, it's a matter of personal choice, which one you want to use. They all have their pros and cons, but they all do the same thing. They suction the hemorrhoid into a channel and then push a band over to trap the hemorrhoid tissue. So I tend to, I don't use ones that need a special suction device to be plugged in, because that just makes it more tedious. And most of them have a handheld suction device, like a syringe plunger, or some have a trigger that will suction air and hemorrhoid into the device. And this is the thrombose hemorrhoid kit, which you should have also, so that you don't go running around looking for stuff when a patient shows up. And so we give, and I have this printed out for patients after a hemorrhoid banding. I explain to them to take Tylenol or Motrin if they're uncomfortable, drink plenty of water. They can sit in a sitz bath. And if they have recurrent anorectal problems and symptoms, I usually tell them to look into getting a bidet, which, it can be as cheap as $30-40 from Home Depot that you can hook up yourself to your toilet to a sophisticated Bluetooth operated warm toilet seat type with a remote control bidet, which I have, by the way. And you get used to those, because then when you go to a hotel, you don't want to go because you're missing your warm, vibrating, whatever. Anyway, so what you have to tell your patients is this is what is bolded. Problems are not common. However, if you start to get a substantial amount of bleeding, severe pain, chills, fevers, difficulty passing urine, you must come to the emergency room straight away or go to one nearest you. This is critical. I give this to them in writing, and I repeat this to them, because although pelvic sepsis is rare, I have heard of people have complications. I have heard of one person who died after a single band that was not followed up properly, because the office staff kept telling the patient, take Tylenol and sit in a bath and chill out. And, by the time he ended up in the ER, he was too sick and he couldn't be saved. He was in DIC. I've seen one case at another institution where there was a rectovaginal fistula that resulted from an infection following a band. So things do happen, and you have to make sure that you did your due diligence and saw the patient and evaluated them. And if anybody comes to the ER, luckily, touch wood, we haven't had this yet so far, but you want to be very aggressive. You want to get their vitals, do an MRI of the pelvis, get surgery to see them if you think that there may be early pelvic infection. And then it just tells the patients how to deal with any discomfort, any mild discomfort. And so it's important to give, I think, for us to give our patients a written handout afterwards. Okay. Now, constipation is also very common. And so I wrote out this spiel about how to talk to them about their, how to get into a bowel movement regimen where they will have their breakfast, have their coffee, go sit on the toilet for 5 minutes. If nothing happens, that's fine. But at the same time, take their Metamucil, their Cilium, and their Miralax. And you all know that if you take enough Miralax, you are going to move your bowels unless there's an obstruction somewhere. So it's not a matter of, is it working? It's a matter of, have you taken enough? And so if you take Miralax in the evening and Metamucil in the morning and a stool softener, you are going to go. And you basically have to get into the habit of having coffee, sitting on the toilet for 5 minutes. And if you haven't gone by day 3, you give yourself an enema. So you have this protocol where you are going to do over-the-counter laxatives, including an enema by day 3 if you haven't gone. And if you start to do that, you will just start going for the majority of people. And that keeps you out of a lot of trouble, such as hemorrhoids and fissures. So we give them this after banding. We give them this handout to make sure that they know not to just take Tylenol and sit on what could be a potentially life-threatening complication. And this we give them so that we are pretty sure that they are constipated. And you can go 3 times a day and still be constipated. And if you look at the Rome criteria, it's not just how often you go, it's how difficult it is to pass stool. And if you are struggling to pass stool, it doesn't matter if you go 3 times a day, you're constipated. So thorough exam of the anorectal area with inspection and DRE and anoscopy are crucial for an accurate diagnosis. 70% of the time, you have a diagnosis just from the history, but you have to do a DRE and anoscopy to confirm. Be sure of the diagnosis. This is not difficult. Explain the procedure, the rationale, and the expected outcomes. And you know, we try to be realistic. If they have grade 3 hemorrhoids, and we go through the banding, sure, it could save them surgery. And they almost nobody says, oh, well, if there's any chance of failure, I'd rather just go to surgery. Nobody will say that. Most of them will say, hey, let's do the banding. Hopefully we can avoid surgery. But you have to have reasonable expectations. But, you know, hemorrhoid banding, I have seen significant prolapsing hemorrhoids where the patients call back to say, I can't believe that just banding did this, that their hemorrhoids, quote, disappeared. Explain potential complications and what to do in writing, as I showed in our handout. Insist that your staff inform you promptly when any patients you have just banded call in with any complications, okay? Because the lawyers are not interested in your staff. They'll come after you if you haven't spoken to the patient. If you have spoken with the patient and documented a plan, then you're okay. Because, you know, complications happen. That's just the nature of medicine. But you just have to show that you followed the standard of practice in the community. Grade 3 and 4, some grade 3 and all grade 4 hemorrhoids will require referral to surgery. And I will stop there and let me just look at some questions and see if we can help here. Okay, it's these slides are going to be available on a recording as soon as we have done the editing. We can certainly send you a link. So I will speak with Rob and see how we can do that. But if I get the link, I will send it to Nalima Reddy, I know, and I have her on rapid dial, so I can always send her a link. And I'll figure out a way to send the attendees a link. Okay, I don't see any other questions. So if there aren't any more, I think we can safely call it a day. Thank you so much for attending. And if you're going to DDW, I'll be doing the symposium session, a clinical symposium session on anorectal disease, and also at ACG later that next year. In the meantime, my email address, wqureshi@bcm.edu. Please send me any questions that you have. Otherwise, I thank you for attending, and we look forward to doing this again next year. And as I said, just in answer to one of the questions, it says, how soon do you offer another set of banding after recurrence? Well, if patients are having symptoms, then you want to look again with your anoscope, and if they have bulging hemorrhoids, you band them again. But it's very rare to have to band somebody more than one session and then within 3 years, if that makes sense. So usually if I band all 3 hemorrhoids one time, I consider that one session of 3 bandings. They're usually, most of them won't come back, but if they do, it's usually after 5 years or so for banding. So, but if they're careful with their diet and not straining and not sitting on the toilet forever, they won't come back. So average of 5 years, but unless they have really bad hemorrhoids, they don't usually need more than one band per hemorrhoid. 3 bands over 6 weeks, and you're done. I hope that answers that. Well, thank you very much for attending, and hopefully we'll see you at the national meetings. And the Baylor course is coming up in March. If for those of you that are around Houston or Texas, you're welcome to come. And that's a very comprehensive, excellent course. And I will also have my say on anorectal disease. Okay, and remember, hemorrhoids, not something you just sit on. You can help your patient and make some money at the same time. Okay, good afternoon, and thank you for attending.